where to do we stand, and our third topic is oil revolution, should we join the fat myths. For that session, I would like to invite our chairpersons, dietitian Meena Charanya from Surat, Shruti Patel from Ahmedabad, and Dr. Kartikeya Parmar from Ahmedabad. Our first speaker is Dr. Shilpa Joshi. I invite Dr. Shilpa Joshi to deliver the talk.
So good morning everybody, and after a beautiful talk by Dr. Amit Mishra and Dr. Soumitra Ghosh, I think this talk has left no relevance, but I have to speak because it's my talk given to me, and it's very interesting. There are a couple of slides in my talk which actually were there in Dr. Mishra's talk as well as Dr. Soumitra Ghosh's talk. What I'm going to speak about is, yeah?
Excuse me, ma'am.
Can't hear.
We just need to introduce you.
Oh, okay. Sorry. Sorry.
Ma'am, we just want to introduce you first. So, Dr. Shilpa Joshi, our first speaker. She is Director, Mumbai Diet and Health Center and practicing dietitian diabetic educator. Faculty, SVT, College of Home Science, Nirmala Niketan. Master Trainer, Diabetes, Conversation Maps. Published more than 12 papers. Recent publication, Start Study, BMJ. Open Course Director, National Diabetic Educator Program, trained more than 3,000 diabetic educators, presented at various national and international meetings, including American Diabetic Association, International Diabetes Federation, and International Confederation of Dietitians. She is Honorable Secretary, All India Association of Advancing Research in Obesity and National Executive Committee, IDA. Runners-up recipient of International Essay Award 2017 of an Academy of Nutrition and Dietetic Foundation of Malnutrition. We welcome you, ma'am, and we are looking forward to learn more from you.
Thank you so much, chairpersons, and I'm sorry that I did not wait for introductions. Got too excited,
okay,
I think. Okay, any which way. So what I'm going to speak about is what makes us eat, and I think if I can answer that, half our problems of our lives are going to be solved. But when I was making this slides, I realized that it is so complex and there are so many sub-factors which are actually playing role. It was interesting to make these slides. Believe me, I was making them till today morning 3 o'clock because there is, for me too, it was a learning process. So I just wanted to begin with something that, we always say we are what we eat. So should we eat skinny people just to be skinny? Because and if it's asking me why I'm hungry is asking me if I would like some more money. It's never enough, right? So same thing is with food. Food is never enough. So now when we are talking about hunger, let's look at hunger from a different angle. Instead of looking at hunger, let us look at satiety, because satiety is absence of hunger. So when we can define absence of hunger, hunger is something which becomes easier to understand. So what is satiety? Satiety refers to postprandial events that affect the interval to the next meal. That is, after eating, when will you eat again is what is defining satiety, thereby regulating meal frequency. And we agree that there is a big problem in regulating meal frequency. And we were just, all of us sitting here were discussing that it's actually how much you eat which is so important. It's hypocaloric diets which are going to be important, and therefore when do you eat next is going to be governed by how satiated you are in a particular meal, which is also influenced by learned habit. For example, sometimes when we get up late, say we get up at 11 and we have our breakfast at 11, come 12:30 we get hungry because that's our lunchtime. So that's habit. So there are 2-3 factors in which play a role. One of them is habit. Satiation results from coordinated series of neural and hormonal signals that emit from the gut in response to mechanical and chemical properties of ingested food, and I'm going to actually dwell upon that a lot in my presentation. It's a busy slide, but what is the function of GI system? Primary function of gut is to achieve effective nutrition digestion and absorption. Many satiation signals are there because they actually influence gastric motility and secretions. Their additional capacity is to limit meal size. Why do we feel satiated? Is because we want to limit as much as we can eat in one meal. Enhances this control by restricting rate at which nutrients reach the gut. Meals are typically stopped long before gastric capacity is reached. Major function of satiation is to prevent overconsumption of food, okay, during individual meals, thereby averting deleterious consequences from incomplete digestion. So, if you eat more, sometimes you get gluttonous, you go to a party, you love food, you eat more. What do you get? Indigestion, right? And that is something that is actually regulated or prevented when your stomach says you are feeling full and you stop eating. That is actually prevented, as well as excessive disturbances in circulating levels of glucose and other nutrients, because if you eat more, you're going to have more glucose rise. So what are the satiation signals? Satiation signals arise from multiple sites in GI system, that is the stomach, the proximal small intestine, the distal small intestine, the colon, and the pancreas. Now, how is the food regulated? Hypothalamus, and I think Dr. Mishra spoke about it so beautifully in his talk, but still I think I need to speak about it again. Hypothalamus is the primary center for food intake regulation, and therefore hypothalamus is what regulates your body weight. Now, regulation of food intake is indeed complex, and it's much beyond this slide what I have shown you, but this is just to simplify it. Food intake is actually governed by three principles. One is homeostatic or energy based. Second is hedonic or reward based. And third is psychological. Okay. Now, within the energy base, there are two main players actually, which is leptin and ghrelin, which we all know about, and most of us are confused about it most of the times. So I'm going to dwell on that. Then there is hedonic or reward based. That is, there is a habit which is created, when we are kids, that when we do good things, we get sweet. So it gives us a sense of pleasure, which is a hedonic response to food. And of course, there is a huge amount of psychological triggers as far as food is concerned. Now we go to the first hormone, which is leptin. Okay, so leptin is produced by adipose tissue. This is a hormone which is produced by adipose tissue. It is also produced by small amount by other human tissues such as stomach, mammary epithelium, placenta, and heart. Leptin is released into circulatory system by adipose tissue as a function of energy stores. So what does it mean? More adipose you have, more leptin you secrete. Okay, therefore leptin levels are higher with a higher BMI, and not always higher BMI. In India, remember, BMIs are normal. It is the body fat percentage which is more. So, for example, Dr. Yagnik's slide, which Dr. Mishra showed, where his BMI was same as the BMI of the Caucasian, but he had a higher body fat percentage of 21% as compared to 8% of the Caucasian. Remember, Dr. Yagnik is going to secrete more leptin at the same BMI. Okay, so role of leptin is about giving information about status of energy stores to the brain. Okay, so leptin is like your chartered accountant who tells you kitna income tax bhara hai aur kaisa ghar chal raha hai. That is what you get, right? So it is like that. So higher leptin, actually, because you have good amount of fat, higher leptin when it goes to brain should drop food intake, because brain gets an indicator that there is enough energy. So you do not need to eat more. So higher the leptin, lower the food intake, and ideally there should be higher energy expenditure, because you have more stored energy to maintain size of body fat stores. Overfeeding in short term and long term increases in adipocyte leptin expression, because when you are overfeeding people or animals, remember, their fat tissues go up. When their fat tissues go up, leptin goes up. Leptin functions as a feedback mechanism that signals to key regulatory signals in the brain to inhibit food intake and regulate weight and energy homeostasis. Leptin is released by adipose tissue into blood system. It crosses BBB's blood-brain barrier and binds to hypothalamic leptin receptor, giving it information about body's energy status. Once it binds to the receptor, leptin influences activity of various hypothalamic neurons, which leads to expression of two kinds of neuropeptide, orexogenic and anorexogenic. So anorexia is a word which you are all familiar. Anorexia means you do not feel like eating. So anorexic neuropeptide inhibit intake, orexic neuropeptide upregulate the energy intake. And these are different kinds of orexogenic and anorexogenic peptides. Um, this is just for research. Really, we do not measure any of this, but it's good to know that there are so many of them. Orexogenic and anorexogenic neurons, which are located at various hypothalamic regions, therefore interact with each other. Compromise in interaction between orexogenic peptide or their effects on anorexogenic peptides has been suggested to be one of the possible mechanisms of leptin action on hypothalamus. So whether you're going to get hungry or you're not going to get hungry is actually decided by interplay of this orexogenic and anorexogenic peptides. Now, this is long-term energy regulation. Why? Because long-term means you make fat, then fat talks to the brain. So it's a long-term thing. But there is also something called as short-term energy regulation by leptin. As leptin is also produced by stomach, it plays an important role in controlling meal size along with other satiety neuropeptide. Several intestinal peptides, insulin, stimulate gastric leptin release. High fat and mixed meal reduce leptin secretion. Less leptin, more hunger. And that is why when you eat a bag of chips, you are never full. You want to eat one more and one more and one more. You keep telling us, last hai, baad mein nahi. But you still eat. That is because you are not a problem. Problem is leptin. Because fat actually drops leptin secretion. Starvation for 36 hours or more actually reduces leptin. That is why after starvation, you feel hungry. Addition to that, anorexia nervosa and exercise-induced amenorrhea reduces leptin secretion. So leptin has two effects, long-term and short-term. Long-term works via adipose tissue to regulate hunger. Short-term works via stomach to regulate meal size. Okay, now we go to the next hormone, which is ghrelin. Ghrelin peptide was originally isolated from stomach, but ghrelin protein has also been identified from other peripheral tissues such as gastrointestinal tract, pancreas, ovary, and adrenal cortex. Secretion of ghrelin by stomach depends largely on nutritional state. Ghrelin levels increases in preprandial state and decrease is in postprandial state. Means when ghrelin is high, you are hungry. When ghrelin is low, you are full, or vice versa. Increased leptin secretion will also suppress ghrelin secretion. Stomach releases ghrelin in the blood. It crosses the blood-brain barrier, binds to the receptors of hypothalamus and affects hypothalamic nuclei. Ghrelin may also reach through vagal nerve and nucleus tractus solaris. Ghrelin is also produced locally by hypothalamus, where it may directly affect various hypothalamic nuclei. Ghrelin attenuates leptin-induced reduction in food intake and body weight by modulating expressions of various hypothalamic peptides. It stimulates orexogenic hormones, inhibits anorexogenic hormone and ghrelin, but does not regulate leptin directly. So what does ghrelin do? Ghrelin actually works on a hypothalamus, induces orexogenic peptides, therefore it makes you feel hungry. So ghrelin also has two-term regulation. Short term, it affects appetite. Long term, now look at gastrostomy studies or your gastric bypass surgeries which take place, bariatric surgeries. Ghrelin levels decrease after gastrectomy, which is most likely why there is weight reducing effect, because there is continuous suppression of ghrelin, not just because the stomach pouch is small. There is suppression of ghrelin and therefore there is reduced hunger. Okay, so this is the interplay of all the hormones, both anorexic and orexogenic, which actually determines how much is the hunger. Now, other stomach hormones. Now, there are again two kinds. There is gastric satiation, which is volumetric, amount based. Okay, and there is intestinal satiation, which is nutritive, that is quality based, macronutrient based. Okay. So what is gastric satiation, which is volumetric in nature? Distension. When you eat, your stomach pouch gets distended. It's a neural secretion of tension and stretch. Output of this sensation is relayed to brain by the vagal and spinal sensory nerves using a complex array of neurotransmitters and neuromodulators. And hence, when pylorus is closed, means the lower end of the stomach pouch is closed, gastric load in it, whatever you eat, just the load in it solely is the basis of volume reduction. The stomach wall is well endowed with discrete neural and sensors of tension, stretch, and volume. Output from these mechanoreceptors is relayed to the brain by vagal and spinal nerves, and hence volume of the food affects appetite, and therefore when you use fiber supplements, okay, people start eating less because it distends the stomach, or this whole thing of eating a salad, etc. What you give to play around with the volume of stomach, this is what happens. Then there is intestinal satiation, which is not, I'm sorry, this is a typo error. It is not volumetric, it's macronutrient based. CCK, that is cholecystokinin, is produced by eye cells of the duodenal and jejunal mucosa, as well as brain and enteric nervous system. It is produced in response to ingestion of protein and fat. CCK induces satiation, inhibits gastric emptying. Hence, protein first, which we follow as a mantra, actually reduces the size, because when you eat protein first, you release CCK. CCK inhibits appetite. Therefore, when you begin your meal with protein, you tend to eat less food. Okay? Then there is GLP-1, which Dr. Anup Mishra spoke about. We know about the ileal brake, which actually decreases the motility of GI system, and therefore GLP-1, which is produced primarily by L cells of the distal, small intestine and colon. Ingested nutrients, especially fats and carbohydrates, stimulate GLP-1 secretion. GLP-1 is inhibited by DPP-4, and therefore GLP-1 decreases food intake in several species, including human, and therefore we find that there are a lot of GLP-1 analogs which are given to decrease hunger. And then there are others. I am not going to go into it because there is a lot and their functions are very small, but just to know, they are oxyntomodulin, there is PYY, and there are fat-specific satiety hormones. So these are all the hormones and all their effects, and this is actually what determines whether you're going to get hungry or you're not going to get hungry. Then there is hedonic response to food. Natural awards such as food stimulate response within mesolimbic system and dopamine reward pathway systems. Presentation of highly palatable food, you know what we see in our ads, burger, puris, okay, they actually induces potent release of dopamine into the nucleus accumbens. This release of dopamine is believed to coordinate many aspects of animals' attempt to obtain food rewards, include increasing arousal, psychomotor activation, and conditional learning. That is, you remember food with pleasure, you associate it. The mechanism by which food stimulates dopamine signaling is unclear. However, it does appear that the taste receptors are not required. Just the sight of food can actually arouse you to eat more. That is why pani puri wala dikhta hai to bhook lagti hai, nahi dikhta hai to bhook nahi lagti hai. You know, it's just the sight of food that actually makes you happy, and why does this happen is really not known. Then there is a huge factor of psychology or stress. Change in appetite, I will need 2 minutes more, chairpersons, okay, because okay, change in appetite is one of the more core diagnostic feature of major depressive syndrome. And if you talk to psychiatrists or even dietitians here will tell you, when women, especially women, because women multitask, so they tend to get depressed more than men. Yeah, when they get depressed, they tend to eat a lot, and they actually find solace in eating and gain a lot of weight. 25% association between mood disorder and obesity. Therefore, people who have mood disorders are obese, and people who are obese tend to get mood disorders. Mice subjected to chronic social defeat stress responded with significant elevation in active levels of ghrelin that correlated with increased food intake and therefore increased body weight. And this has been proven in animals. Now, this is 1 minute that I want you to dwell on this study. When I read it, I was extremely impressed. It's a small study, but actually talks a lot about food intake. So this was done by Dr. David Cummins' group in University of Washington in USA, where they actually calculated acyl and total ghrelin in people who were consuming various kinds of macronutrients. Okay, now acyl ghrelin is the bioactive form of ghrelin. So in blood, you can calculate total ghrelin as well as acyl ghrelin. Acyl ghrelin actually is the bioactive form of ghrelin. Total ghrelin is anyways there. So what was this done? It was a small study. 7 men and 9 women, 25% were Caucasian, between age of 20 to 65 with a range of BMIs from 20 to 30. Okay, fasting baseline hormonal and nutrient measurements were equivalent across all the study. What were these people done? These people were given isocaloric diets. Okay, so remember, calories were same. Okay, in one diet was 80% carb, other diet was 80% protein, and third was 80% fat, and they were beverages. They were given, I'm sorry, but I'm going to take 2 minutes more. Yeah, is it okay if I take 2 minutes more? Yeah, yeah. They were given this test beverages, and their blood samples were collected at, at 9, say they were given, and then at 9 a.m., 11 a.m., 1 p.m., and 3 p.m., so over 6 hours. Okay. This was the macronutrient composition of that diet. This paper is freely available on Google. Don't take photographs, you will get it. Just put David Cummins and you're going to get this paper. Now, what was the result? Interestingly, carbohydrate beverage increased. Is there a pointer? Carbohydrate beverage actually increased the glucose level the greatest, expected, right? But look at protein and fat. There is a flat line right up there. So there is a flat line there. So as insulin levels were highest when there was, because carbohydrate induced insulin secretion, insulin levels were highest when the carbohydrate beverage was consumed as compared to protein and fat. Okay, look at triglycerides. When there was a lipid consumed, the triglycerides were highest, followed by protein and then fat. And look at leptin levels. Leptin, higher the leptin, lesser the hunger. When there was lipid consumed, because there was higher leptin. Now look at ghrelin levels. What is ghrelin doing? Ghrelin is making you hungry. Ghrelin is inducing you to eat food, correct? So when carbohydrate were consumed, look at the ghrelin level. Look at the peak after 5 to 6 hours. Look at that on top. Yeah, and acyl ghrelin is the bioactive form of ghrelin. Okay, so as soon as you eat carbohydrate, look at in couple of hours, look at where your hunger is. Okay, as compared to protein, look at where your hunger is. And that is why protein, very little hunger. Carbs, a lot of hunger, because ghrelin is high as compared to lower ghrelin after consumption of protein. And that is why when we eat our breakfast with poha, upma, idli, dosa in 3 hours, I am hungry again. If you ate an egg, you are not going to get hungry after 3 hours. You're going to probably get hungry after 5 hours. And it is the meal frequency which is going to determine your net caloric intake. You may eat good food, but you will eat food nevertheless. Yeah, so calorie is a calorie. Other metabolites which affect appetite: lactate, pyruvate, and ketones inhibit feeding. Postprandial circulating lactate concentrations are increased in proportion to the carbohydrate content of the meal, and therefore they inhibit food intake. Probably metformin works in this way because it sort of increases the lactate levels. Then there are ketones. Now there are two kinds of ketones. One ketones is in mild starvation. When ketones increase marginally, you get hunger faster. So when you are starving for a day, you do upvas. Now Navratri is coming, no? So if you're starving the whole day, you are not going to create tons of ketones. Very mild elevation of ketones. At night, you are going to be waiting. Kabhi, wo hota hai na karwa chauth mein, kabhi chand aate aur kabhi khana milta hai. Right? It happens that way. But if there is a long bound starvation, okay, or there is ketogenic diet where there are high amount of ketones for a longer period of time and the ketone levels is pretty high, you find that there is reduction of appetite. So ketones work two ways. If there is mild elevation, there is hunger, but if there is a good elevation, then you find that it actually suppresses hunger over a long period of time. Then others are cytokines, for example, IL-6 and TNF alpha, which actually increases when you have infection, which reduces appetite. Glucocorticoids, when steroids are given, appetite upregulates. You feel more hungry, and therefore in Addison's disease, where there is glucocorticoid deficiency, you tend to lose weight. But in Cushing's syndrome, where there is glucocorticoid excess, you tend to gain weight because it works on your appetite. Then there is thyroid hormone. Again, it's not really well understood, but when there is hyperthyroidism, your metabolism is up and therefore your hunger is up, but you still lose weight. And when there is hypothyroidism, apparently your hunger is lesser. Growth hormone, again, when growth hormone is at its peak, there is more hunger. So last slide, I'm ending it now. Conclusion, why do we feel hungry? It's $1 million complex question. It is an interplay of many factors which include psychological, hedonic, and physiological and psychological and hedonic. Experiments have proven that composition of meals in terms of macronutrients has an effect on satiety hormones and hence hunger. Understanding some basic principles and interplay of nutrients and hunger or satiety will help selection of foods which might help to combat growing problems of metabolic diseases in India. Thank you so much for a patient hearing, and I'm extremely sorry to have taken 5 minutes more.
Abhi. Thank you very much for nice talk and the food intake and the hormones, ghrelin and leptin and GLP analog. Now, any questions for the audience? Yes?
So, the effect of ketogenic diet on insulin sensitivity is by loss of fat tissue. So, on a ketogenic diet, when you say a diet is ketogenic, what does it mean? That it has high amount of ketone bodies secreted. How are ketone bodies made? By breakdown of body fat. So, when there is fat loss, automatically there is increase of insulin sensitivity. So therefore, it will work on insulin sensitivity in positive way if ketones are positive. And please remember, ketosis and ketoacidosis are two different things. So diabetic ketoacidosis is doing nothing with ketosis, okay? There is no pH change of blood when there is ketosis. Whereas in diabetic ketoacidosis, it is accompanied by acidosis. So they are two different things. So mild ketosis will of course always increase insulin sensitivity. Well, good is, it is like a sword. If you kill somebody who is your dushman, it is a good thing. If you kill your friend, it's a bad thing. You should know how to use ketosis to your advantage.
Thank you, Shilpa.
Thank you.
Now, I request Shruti to felicitate Shilpa. Registration done.
So, one housekeeping announcement. All India Association for Advancing Research in Obesity, that is RO, if you want to become a member of that society, I am secretary of that society and Dr. Sabu is the president. The forms are available on registration desk in case you want to do it because we are having a offer for membership right now. Thank you so much.
Thank you, Shilpa. And our next topic is diabetes reversal with diet. Where do we stand? For this talk, I invite Dr. Anjali Bhatt.
Very good morning to all of you. I would like to introduce Dr. Anjali Bhatt. She is from Pune. Her qualifications are she is Doctor of Medicine, PDFD, Diploma in Endocrinology, Masters in Endocrinology. Her key work and roles and responsibilities are she is in charge of in-hospital diabetes management at Chelaram Diabetes Institute. Her expertise is in hospital management of hyperglycemia, community based diabetes research, diabetes reversal through meal management, chapters in endocrine, diabetes books, publications in prestigious national as well as international journals. She is speaker at various national and international conferences. We welcome you, ma'am, today.
Thank you so much, Chairperson, for the kind words. So, reversal of diabetes with diet, where do we stand? There are a lot of questions in diet, there are a lot of research getting generated nowadays with diet. But I think somewhere we are yet to understand its full potential in management of diabetes. So let's see what I have to discuss in this talk today. We are going to discuss the most disturbing patient which are dealt by us during our clinical practice in India. What is the global as well as Indian evidence about reversal of diabetes with diet? Which diet is best for reversal of diabetes? Is it reversal of diabetes, of pathophysiology of diabetes, or its remission, or its normalization, or its cure? What does it mean? What these words mean to us? And why suddenly there is a eureka about use of diet or importance of diet in diabetes, especially in the reversal of diabetes? So this is a real patient, seen by me around 7 to 8 months back. 17-year-old boy diagnosed with type 2 diabetes during the 12th class examination. His weight was 102 6 months back and went down to 94 kgs in last 3 months. His father has diabetes. He has acanthosis and blood pressure is 166 by 90. We did confirm that he has type 2 diabetes by checking C-peptide as well as GAD antibodies. So we're not talking about type 1 diabetes. We are talking about type 2 diabetes in young. I'm sure those of you who have listened to Dr. Tandon yesterday, that 25% of our patients who are less than 25 years old are type 2 diabetes. And within 20 to 25 years, the percentage is 80%. So 80% 20 to 25-year-old diabetics are type 2 actually, not type 1. So this is our most disturbing patient. His HbA1c was 13.6 and triglycerides were 320 milligram per deciliter. Now, this is the natural history of Yash. Because we know from UKPDS that whatever you do, irrespective of which drug you use, irrespective of whether you control diabetes strictly or you keep it loose, every drug given for diabetes loses its potential in 2 years. So irrespective of whatever you do, the HbA1c raises by 0.5% every year, and within 2 years, you are bound to add another drug to the regimen. And there is no escape from this. And finally, you land up in insulin with the consideration that we have around 5 classes of drug for diabetes right now. In 10 years, this person is going to be dependent on insulin. So a 17-year-old boy is going to become dependent on insulin at the age of 25 to 27, and then he has to lead the rest of his life with the standard basal bolus therapy, that is 4 injections per day. And this is very disturbing. Why? Because the way the diabetes is proportionate in India, it is epidemic. Around 10%, 10 to 15% of our population is diabetic today, and the rate is going to become double in next. The prediction is 20 years, but what I feel is it's 10 years. 10 to 15 years, the prevalence is going to become double. And we are going to deal with these younger generation or younger population with diabetes who is going to fail in 10 years, and 10% of our population is going to become insulin dependent, and it is getting costlier every day. Every invention of a new drug is adding 50 rupees per day to the regimen, which is really, really costly for an average man in India. So are we looking in the wrong direction? We are going in the direction of finding out a new drug every 2 years, and we are experiencing that this drug is failing every 2 years. Should we look back? Should we look back at the pathophysiology of diabetes, and should we think of whether we can go back in that direction rather than going ahead, which is a wrong direction? So the first incidence or first evidence came from bariatric surgery, where they told us that it is possible to manage diabetes without drugs. So after the bariatric surgery, initially with gastrectomy and later on with Roux-en-Y and bypass surgeries, that it is possible for diabetes to be controlled without anti-diabetes medications. And what they thought was there are 2 reasons for this. One is calorie restriction, obviously, because of the size of the stomach becoming smaller. And second is stimulation of the hormone, about which Dr. Shilpa spoke so eloquently just before me. But the thing is that these hormones, these ghrelin, leptin, and majoritarily GLP-1 analogs, which are considered to be one of the factors which are responsible for reversal of diabetes after bariatric surgery, are not that potent. Because we know from the incretin-based therapy, we know from the GLP-1 analog receptor-based therapy, that people do not lose more than 4 to 5 kgs with GLP-1 analog. Whatever strong GLP-1 analog you use, within over 6 months period, they do not lose more than 5 to 6 kgs if the other part, diet and exercise, is not considered. So this looks like to be the lesser potent mechanism. The more potent mechanism looks like to be calorie restriction and not the hormonal things. And this was highlighted by Dr. Porris, who is considered as the father of bariatric surgery in the world. In 1995, he opened up a patient for the gastrointestinal surgery, not exactly bariatric. And without doing the surgery, he went out because of some surgical complication, and found that because of calorie restriction after this normal gastrointestinal surgery, the person's diabetes went off. So even without doing the bariatric surgery, the calorie restriction took this person from having diabetes to having no diabetes. And this is the first study, first evidence-based, properly randomized controlled trial where 11 patients with type 2 diabetes with average duration of 4 years were put on very low calorie diet. Very low calorie diet, I'm sure there are a lot of dietitians here and you are very well versed with these terms. Very low calorie diet means less than 600. Low calorie means less than 800 to 1000. So very low calorie diet for 8 weeks, that is 2 months, made all of these patients have normal blood glucose without any drug. In 2 months, all these patients went back to normal, not only normalization of glycemia, but also normalization of pancreatic fat, normalization of acute insulin phase response, normalization of first phase insulin response, and hepatic insulin sensitivity also. So they did clamp studies, they did MR spectroscopy of the fat, liver as well as pancreatic fat, and they found out that not only blood glucose becomes normal, but also the pathophysiology of diabetes goes back in the reverse direction, which does not happen with any of the anti-diabetes treatment. No other drug does that. Now you will say, what after 2 months? So they continued this study for 6 months. After 2 months, 3 to 5 months, they put these patients on isocaloric diet. So this very low calorie diet was given for 2 months. After that, the patients went on isocaloric diet, and they found out that 50% of them still remain on diabetes at the end of 6 months, even after going back to isocaloric diet. Now this is how he thinks. Reverse pathophysiology of diabetes. What takes years to develop: insulin resistance, lack of insulin sensitivity, a reduction in the insulin secretion, takes years to develop. And within few days, with low calorie diet, the pathophysiology actually goes back. And this is evidence-based. This is not a hypothecation. So this is how he explains the twin cycle hypothesis. I will not go into the pathophysiology because of the time constraint. The limitation is that 600 kilocalorie diet with total replacement of meal with meal-based formula is something which we feel is not practically possible. So what he did, that he did it in primary care center. We believe that our patients will not follow it. But when he followed this in a primary care center, there also he saw that practically it is possible to give such a diet in primary care setting. You are giving drugs to them. They are accepting drugs, which they are going to take for lifelong. Why not give them this option? Some of them will be ready to take it. So it is possible to give it even in a primary care center, but this is UK based. So they found out that 0% patients who are on medicines lose weight, and almost 25% patients who are on this lose at least 15 kgs weight. And the proportion, it was a linear proportion. Every 1 kg reduction is going to improve the chance of reversal. Complete normalization of blood glucose, 46% with low calorie diet. So 50% of your type 2 diabetes patients are going to get controlled without drugs. This is a very huge sentence. And the odds ratio is 19. I'm sure no other drug gives that type of odds ratio. So this was, you will say that, okay, UK people will accept, our patients will not accept. So this was Indian study done by our group where we gave low calorie diet, not very low calorie. Low calorie, 1000 kilocalories with 1 or 2 meals replaced by protein formula, and rest of the diet they are eating home-based diet. And what we found, that the baseline HbA1c of 9, 2 years back, I would not dare to put my patient who has 9 HbA1c just on diet without a drug. But today I do it. So 12 patient, very small study, but the baseline HbA1c of 9 and became 6.2 at the end of 3 months with just 1000 calorie diet, only 1 or 2 meals replaced by protein formula and rest of the diet given at home. And the protein formula was also added for the research purpose, so that we have something fixed in those 12 patients and the data can be analyzed. So weight reduction, HbA1c normalization, C-peptide normalization, serum insulin normalization, reduction in the insulin resistance, and improvement in insulin secretion also with low-calorie diet. So the conclusion of these studies is that it's possible to achieve normoglycemia with low-calorie diet and without any anti-diabetes medication, even in patients with type 2 diabetes mellitus and significant hyperglycemia. What we know about diet is important in managing diabetes, and people who have mild hyperglycemia should be put just on diet without drugs and followed up. But irrespective of what is the baseline level of hyperglycemia, low-calorie diet has a potential to make the person completely normal and manage the hyperglycemia without medicines. It is possible, and it is now shown by evidence. Obviously, it's a small study. The larger studies are going on, but the result of this study were so intriguing for me that I have in my private practice started putting every patient on diet at least for 1 week. I do not start anybody on drugs who is coming to me for the first time. Never. Now you will ask me, what diet? This low-calorie diet, fine. But what diet? Is it carbohydrate? Is it protein? Is it fat? Is it whole grain? Is it home-based? Is it outside? Is it protein formula? We have only one definite answer, and that is low calorie. So reduce the calories, and you may eat, I don't know how much true this sentence is, but you may vary the diet if you are eating less. Now, there are a lot of types of diet suggested by every nook and corner of the country, by dietitians, by clinicians, by quacks, by non-medicals, by non-clinicians. Eat only 2 times a day, eat buttermilk in between, eat protein-based diet, eat ketogenic diet, eat carbohydrate-rich diet, eat 50% carb, eat 40% carb. If you can reduce your calories, you can eat anything, is what I'll say. The final thing is that eat less. If eating less, if you are okay to eat 1000 calories of fat per day and okay with it, I don't know what will happen, but I think you cannot contain yourself. In 1000 calorie with only fat, you can't contain yourself. So the next thing comes how to balance these 1000 calories. And there comes that 1000 calorie diet which makes you full, which keeps you energetic, which will be sustainable. Not for 1 month, 2 months or 3 months, but sustainable diet which makes you full and which is low calorie is fine. Let the patient experiment with the diet, monitor their blood glucose, use whatever continuous glucose monitoring systems, glucometers, whatever technology you have, monitor them. Don't tell them this is what you have to do, because individualization is very important. There is no one such diet which you can form as an algorithm, do this, do this, do this, do this, do this. The patient is most likely not to follow. Let them experiment with their diet. Let them eat what they are eating. Let them come back with a diet plan or diet chart which they are eating already, and then review it and modify it. I know it takes a lot of time, but the kind of epidemic we are dealing with in India about diabetes, drugs is not going to be the answer. We need to individualize, we need to study patients, we need to come out with answers for diet. But one answer we definitely know, that is reduce how much you eat, low calorie. So whether it is reversal, remission, normalization or cure, there are some definitions. They are saying that reversal means that there should be normal glycemia for at least 1 year. Some are saying there are for normal glycemia for 6 months. HbA1c should be below 6.5. Some are saying HbA1c should be below 6. The recent evidence suggests us that we should reduce the threshold of what we call as reversal. We shouldn't be waiting for them to have normalization for 1 year. We are starting them on drug on day one just because we want to bring down the blood glucose very fast. Why are we not looking at the faster reduction of blood glucose with diet? Our patients had normoglycemia from blood glucose at baseline of 300 within 3 days. 3 days of low calorie diet, and on third day these patients are having normal blood glucose. So what Dr. Roy Taylor suggested recently, that HbA1c done at 2 months interval twice if it is normal without drugs, we can call it remission or reversal or cure if you want to say it and motivate your patients. So what happened to this person? 17-year-old boy, obese, type 2 diabetes, diagnosed with HbA1c of 13.6. We did not put him on any medication. No drug. Started him on low calorie diet, 1000 kilocalorie, 2 meals replaced by protein formula and rest of the meals at home-based meals. Within 3 months his HbA1c was 7.5 without even a single drug, and he lost around 10 kgs in 3 months. He was started on metformin at the end of 3 months, 500 twice a day, and after 3 more months, an isocaloric diet, and after 3 more months his HbA1c is 6.1. Do we call this reversal? Do we call this remission? Do we call this normalization? Whatever we call it, I think the amount of treatment he would have required at the HbA1c of 13.6 when he came is definitely tremendously higher compared to metformin 500 mg twice a day. And if I would have put him on these medicines on day one when he came to me, he would have never got motivated to look at the diet. Look at the tremendous motivation I as well as the patient is getting when he knows that the HbA1c can be brought down from 13.6 to 7.5 without any single drug. I would not have dared to put my patient who is 17-year-old with HbA1c of 13.6 just on diet few years back. But today I'm doing it for everybody. So give diet a chance. And why suddenly we're talking about this? We always knew, isn't it? Can anybody guess who this is? It's Galileo. And he sort of discovered that the earth is round. Was earth flat before he discovered it? No. The earth was always round. We always knew that the diet is important, but probably we underestimate its potential. We think that diet control is only for people who have mild hyperglycemia and can be put just on diet. And once you cross a certain level of HbA1c, the person must be on anti-diabetes medicines. That is not true. We need to understand the full potential of changes in lifestyle for management of diabetes. Just need to give enough chance to diet and exercise, at least 1 week, 1 month, 3 months. Give some chance to your patient just to manage with diet and exercise. So this is the last slide, summary. We know that India is harboring young diabetes people with type 2 who are going to be insulin dependent in next 10 to 15 years. We know that the calorie restriction is the basis of reversal of diabetes even with bariatric surgery. There is a huge potential of managing around 50% of your patients just with diet and exercise, irrespective of whatever is the basal hyperglycemia level. Indian data also suggests that 1000 calories is also fine. Some reduction in calories is always better than continuing with the same calories. And we should not underestimate the potential of diet and exercise changes, especially the low-calorie diet, in complete reversal of diabetes and complete normalization. I would dare to call it a cure. Thank you so much.
Thank you very much. And any question from audience?
Can I just ask a question?
Sir, as I said, the proportion is 50%. Underweight diabetes, overweight diabetes, insulin deficient diabetes, type 2 diabetes, hyperinsulinemic type 2 diabetes mellitus. What we understand diabetes right now is not complete. We do not understand each and every patient of diabetes. So I'm not saying anti-diabetes medications are out. I'm saying that 50% of your patients can get managed with diet and exercise. Underweight diabetes, again, if you are calling them on the basis of BMI, then we have seen since yesterday that BMI is not the way to assess these patients who have type 2 diabetes. So we are talking about obese. We are not talking about lean diabetes. We need to further classify them, and I'm sure in them also this will work, but we are yet to get the evidence.
Is there any way by which you can know that these are the patients who will go in remission or
Right.
cure?
Yes. So definitely C-peptide has to be done, which has to be normal. We're not dealing with insulin deficient patient. So type 2 diabetes, one. Second is obesity, BMI more than 23 in Indian people. Anything more than 23 people will respond. And third, by Dr. Roy Taylor's experience, higher basal insulin in the beginning. The chances that patient will reverse with diet are higher.
So Anjali, very
But
interesting
still,
study.
it was more, I mean, not more than 11% of the patients who can get the remission. In even
50%, sir.
So
46%.
but in Indian situation, there was one more study which was a short term because the compliance is real difficult.
Right.
I mean, if you just talk about the randomized controlled trial, but we have our own clinical experience doing this type of reversal by giving them a therapy. I'm sure Rucha must be having more number of
I have
patients on the similar, but the issue is not more than 10 to 15% of the patients are compliant,
So
and that too not for a very long period of time.
Right.
So to tell them it is cure is real difficult. We tell them it's in a remission phase and it is to be continued lifelong.
I understand, sir. Absolutely. But when we give medicines to them, do we tell them that you have to comply with them for lifelong? We do tell them, and they do follow it because we believe in it, isn't it? Unless we believe in it, we will not be able to tell them confidently. I am sure there are certain group of patients we are dealing with are ready to follow a particular change in their life for lifelong, because that is going to be, we are not talking about today. Maybe today more patients are on medicines and less patients are on diet. I am talking about 25 years from now. Do we want our whole population to be on anti-diabetes medication? The thing has to change. We need to change our mindset, and we need to change patients' mindset. I'm sure we need more evidence, but unless we give it a thought, we will not generate the evidence. That is what all I need to say.
Yeah, thank you, Anjali, for a great presentation. In fact, you should have been on our DPL team in favor of monotherapy yesterday. I have two questions for you. You showed us before and after. If you can just tell us the duration that it took to get your patients into remission.
3 months.
3 months.
Yes.
And secondly, I agree with you that calories do matter, but I'm sure you've done body compositions, looking at basal metabolic rates, maybe even knowing only indirect calorimetry. So my second question is, one size does not fit all, as you might agree. So I highly suggest or recommend, since a dietary prescription was given, that you do a macronutrient assessment. And I think there'll be a greater impact of the percent, because my understanding is that they could not have got more than 40 to 50% carbs if 2 meals are replaced by a protein shake.
Yes.
So therefore, I think there has to be an impact of macronutrient composition.
It was 60% carbohydrate, 20% protein, and 20% fat. The
Right.
article is published in Indian Journal of Endocrinology and Metabolism. We have given the menu chart. We have also given the macronutrient composition, but because of lack of time, I could not discuss it in detail.
Absolutely. So,
Yeah.
because I think that might be in our Indian scenario, if they don't, make
Yes.
it more palatable.
So
to
that
go
is
with the
what.
macros.
That is what. If we try to look at everything together, we'll get confused. So if we find a thread and if we follow this, if we find a thread of low calorie and then try to distribute those calories, it will be easier. Rather than saying that you eat protein, you eat how much ever you want, is the thread I think we are not getting correct with. If we follow that, I need to eat 1000 calories, and then what will give me satiety? Obviously, carbs will come down and protein will come up. So I just suggest a thread of low calorie.
So, and in your study, did you look at predictors of remission?
We did look at predictors of remission, and as I said in the earlier question, type 2 diabetes, higher insulin response, higher insulin level at the beginning, and BMI more than 23, and fourth one was duration of diabetes. That is one thing which in lack of time I couldn't discuss, is that people with less than 5 years of duration of diabetes are more likely to respond, but I have seen people with 10 years of diabetes on insulin going off insulin but remaining on medication, and I would call that also reversal or remission. We don't have that much data because we don't have that statistical significant sample to do that, but Dr. Roy Taylor has seen that the acute insulin phase, first phase acute insulin response does go up.
Ma'am, for how long you can keep a patient for a very low calorie diet? After 3 months, then what? The management after 3 months, that I want.
So right now we have data only for 2 months. Dr. Roy Taylor's data for very low calorie diet is 2 months. But after that, the patients are going on isocaloric diet, and even after going back to isocaloric diet, for 6 months, they are remaining normoglycemic, even after going back to isocaloric. So very low calorie diet for 2 months followed by isocaloric diet, still they remain normalization. So we need to reduce the calorie. How much, whether very low calorie, very low calorie, very low calorie, we are yet to understand better. But what we found that for survival, we really need much less calorie than what we think.
Okay. One quick question or a suggestion. Hello, Dr. Anjali. Would you be considering an option where, for example, we reduce the overall energy consumption by reducing the heart rate during this intervention? Because we are adding, we are reducing the calorie. If we can stop the heart, in the sense that reduce the rates to about 100,000 heartbeats to about 90,000, it would help the system manage the overall journey during the first 2 months. And there are techniques to do that, non-pharmacological techniques.
I personally feel it is better not to externally deal with these physiological systems, because heart rate is not only for energy consumption. There are other things that heart does. So
I meant, sorry, non-pharmacological changes, reduction. So it's
so basically, if whatever intervention you do, if basal metabolism comes down, the heart rate will come down, energy consumption will come down, all those things will happen. But exercise is something which is more useful to do that. And heart rate alone, judging that, I don't think that will be, it will be too simplistic probably to say that.
Just to conclude, what I meant was regulate the emotions, thereby reducing the energy consumption of negative emotion.
Initially that will happen. And
if we can supplement what you're doing with that, would it help overall progress?
We must see. We must be open to everything.
Anjali madam, you are talking about just one question. You are talking about the so much less calorie diet. So is it respective or irrespective to the BMR of the particular patient? And what about associated exercise patient is doing?
Right. So these patients were given 1000 kilocalorie diet irrespective of their BMR, irrespective of their weight baseline, irrespective of their previous energy intake. As you said, we need to individualize this. But when you need to do a study, you can't do study with individuals. You have to show that this works in many patients. And for that, this thing was made consistent, 1000. But as you said, we must decide which diet is better for each individual. And that is how we have to keep our eyes open and create new evidence as to how to categorize the patients to particular diet. Maybe some people respond better to carbohydrates, some respond better to protein, some respond better to fat. We need to understand this.
Okay, thank you very much.
Thank you so much.
Excellent talk. The conclusion is that low calorie diet and reduce the weight, you can help to reverse the diabetes. Now our third speaker is Dr. Vanisha Nambiar. I would like to request Minas to felicitate our speaker, Dr. Anjali Bhatt. Our third speaker is Dr. Vanisha Nambiar, and the topic is All Revolution Should We Join?
Welcome, Dr. Vanisha Nambiar. Dr. Vanisha Nambiar is from Baroda. She is MSc and PhD in nutrition. She is full-time professor in Department of Foods and Nutrition, Faculty of Family and Community Sciences of MSU University of Baroda, and she has experience of 26 years in teaching and research. Dr. Nambiar has been the Secretary of Gujarat State Indian Dietetic Association for 8 years under mentorship of Her Highness late Dr. Mrunalini Devi Puar, then the Chancellor of MSU University of Baroda. We welcome you, Dr. Vanisha Nambiar.
Thank you, ma'am, for the kind introduction. Before I begin, I would like to thank the two people who have started this revolution of diabetes education, introducing new trends in diabetes, and running for diabetes-free India, Dr. Bansi Sabu and his entire team. Well, I'm so thankful to the speaker of the plenary sessions, Dr. Anup Mishra and Dr. Ghosh, who has spoken most of what I have in my slides. So what is this oil revolution, and should we join the fat myth? Welcome to Gujarat. Over past 3 days, I think you would have really enjoyed the jalebis, fafdas, gathias, dhoklas, and even in today's breakfast, we had fafda, jalebi, as well as bhakarwadi, right? So what should we be eating? All cooking oils actually are composed of 3 different types of fatty acids. Monosaturated, polysaturated, unsaturated, as well as saturated. And all the oils are categorized on these types. So there are several types of fatty acids in each group. Fats from coconut oil, vanaspati, animal fats, that is ghee and butter, and animal foods like milk and milk products. They provide saturated fatty acids. The short and the medium chain saturated fatty acids present in ghee, butter, and coconut oil are not so bad. They're easily digested, and therefore they're good for infants, young children, and for several of the patients, MCTs are a boon. This is a summary of lipid function and metabolism. And finally, it, it says that whatever you eat digested may go here, but the extra fat, what is extra will be discussed now. It will be stored as your energy reserve, and it's important to have good amount of fat in the body because they provide insulation, they support vital organs, and they generate heat. So even if you are on a very low calorie diet, I got up actually twice just now to ask what was the macronutrient distribution, but never got a chance to interact with the previous speaker. Now, oils, they have a natural flavors, okay? And that natural flavor is due to the minor components. Say, for example, tocotrienols in the palm oil, lignins in the sesame oil, oryzanol and tocotrienols in the rice bran oil, and they all reduce cholesterol, okay? And refining of oil actually does not alter the fatty acids, but they do modify some minor components. Example, the carotenes are lost. But this is again another biochemistry figures, and which shows that here after the metabolism of fats and lipids has been completed in the presence of aerobic respiration, they finally will go, if not into lactate, the TCA cycle. Now, the cooking oils are, as I said, divided based on their monounsaturated fatty acids. So this is a profile, the polyunsaturated fatty acids of the few oils, and the saturated fatty acids of the commonly available oils. PUFA are essential component of the cell membrane. They are prominent in all the cells of the body, and you need to have appropriate balances of 2 classes of PUFA, that is the linoleic and the alpha-linolenic acid in the diet, okay? And PUFA, particularly the N3 PUFA, they increase the insulin sensitivity and peripheral glucose utilization, and therefore they are anti-atherogenic, and we need to have them in our diet. So what's the controversy? We've been talking about coconut oil, so let me start with that. The lecture by the Karine Marshall's professor, Harvard University, and they said that coconut oil is pure poison and you should not be eating. And thereafter, we had a lot of controversies and professors talking about the unsaturated part of the coconut oil, which is good or bad, and it is actually spoiling our health. Yes, coconut oil is highly saturated. It has 92%, and you should be using it sparingly. But what about the entire state of Kerala then? Yeah, and which is the right oil for you? Well, oil, whatever the type of oil that you are using, finally what happens in the body is how you treat that oil before you use it. So it depends on the type of cooking you're doing, whether it is sauteing, steaming, or deep frying. And if you're doing deep frying, how many times are you reusing the oil?
Another part is the smoke point of the oil. How fast does the oil get heated up, and whether it is used for frying or it can be only used for seasonings. And if you use the oil past its smoke point, it is harmful not only for the flavor, but also it will form harmful compounds called free radicals. And as you know, all the inflammatory disorders are because of high amount of free radicals in the body. So the most versatile and healthy oil we've been talking about is olive oil. However, please ensure that the olive oil should be extra virgin, just not by label, but it needs to be lab tested, because not all oils available in the market labeled as virgin oil are virgin. So please make sure about that. In Gujarat, we consume loads and loads of peanut oil. It is highest in MUFA, around 49%, has good amount of PUFA as well as saturated fat, but it is actually better as compared to the coconut and the palm oil. Now, what is this palm oil? I'll be talking about it shortly. Another flavoring oil that is commonly used is the sesame oil, talnu tel. Now, it is also rich in polyunsaturated fat, has good amount of MUFA and has 14% of saturated fat. It has less smoke point, is quite low, and therefore only used for flavors added in your dhoklas and handwas and muthias. That is what is the common trend here. The next one is the sunflower oil. Light in color, has 69% of polyunsaturated fats, and has 20% of MUFA, 11% of saturated fats, and is a good option for a healthy heart. Another one for a healthy heart is soya bean oil, because it has 61% of PUFA, 24% of MUFA, and has good amount of omega-3 fatty acids, which is also good for the heart. Now, what is this omega-3 and what is this omega-6? Now, omega-3, omega-6 competes for the same metabolic enzymes. The metabolites of omega-6 are significantly more inflammatory, okay? And therefore, you need to have a correct ratio of omega-3 is to omega-6 and not have an oil which has too much of omega-6 in the diet. So, now we come to the saturated fat. Saturated fats can also be healthier oils when you use, especially for frying. And we know our desi ghee, our jalebis are best tasted and last longer when they're cooked in desi ghee, because they have the best smoke point. 1 tablespoon of ghee provides around 45 mg of cholesterol, that is 15% of your daily value. Ghee also has other things besides calories, and as considered as the best oil for baking, sauteing and deep frying. I'm talking about the culinary usage of ghee and not for the hard part, okay? Now the next part is the trans fat. We love all these items. They are displayed during tea time. They are served during all conferences. And I wish that any conference planner, they should actually take tips or hire a dietitian to plan a menu, especially for DiaCon conference, okay? So, we know the trans fat is bad for us, and I need not discuss more about it.
Hotel is not allowing.
I will, sir, do it for free.
But hotel person is not ready to serve that. That's the issue.
You put your foot down as that you're giving them business, okay? Right. So, thanks Dr. Sabu for intervening. Now, the next part is the palm oil and the palm kernel oil. Now, there's a difference between palm oil. The red palm oil, we've been talking about red palm oil, imports of red palm oil, government actually getting red palm oil subsidies because of the carotenoid content. They all both come from the same palm tree, but the red palm comes from the fruit and the palm kernel oil is from the seed. Now we don't see what is it, because we only read palm olein on the label, okay? But the difference is, there's a lot of difference, because 80% of the fat from the palm kernel oil is saturated versus only 50% from the palm oil, which makes it easier for the arteries. And palm oil is the oil which has actually reversed vitamin A deficiency and blindness in several countries and is therefore been recommended throughout the world. So when you look at these dabbas of palm oil, please see whether they're not labeling it. That's the best part. They only say it's palm oil. They don't say it's kernel or it is from the fruit. So you need to be smarter. And if you love your banana chips, you get your palm oil fried, but we don't know which palm oil. And you also love your banana chips, which is coconut oil. They are freely labeled. And our love for food will never, cease. But you should learn how to read labels. That's what I would be recommending. Another very, very popular oil of Gujarat is the Kapasyanu Tel, the cottonseed oil, okay, which is the culprit of the Gujarat being the diabetic capital of the world. Everything is cheap. All farsan is a necessity in Gujarat. Whether you have your dal, bhat, shak, rotli, you have to have some chivda towards the end to complete the meal, okay? And the chivda is very cheap as compared to some other stores because it is made from the cheapest, either palmolene or Kapasyanu Tel. And on hydrogenation, the saturation obviously increases. That should also be considered. And most of the farsan in bakery, the khari, the naan, the toast, the puff, most popular among children is made from this hydrogenated Kapasyanu Tel. So India is the largest producer among all the oilseeds. The Kapasyanu Tel is maximum in this country. And there are some oils in vogue, the avocado oil, the walnut oil. There's also some almond oil, if you can afford. Yes, buy them. Some more biochemistry. If you have a fiber-rich diet, you have a good control over your glucose. If you have a low fiber deficit diet, you will end up in inflammation and obviously the diabetes follows, okay? So just remember, please have good amount of fiber in the diet. Don't even bother remembering these things. Now, the recently most modest increase in the plasma content of LPS have been incriminated as the etiological event causing metabolic inflammation, and that is, my previous speakers have also mentioned, and we also have a lecture in the evening, the topic about gut microbiota. We are just ignoring our chas and curds, and we have no chas and curds after meals. I don't know why, but you need to have healthy gut. That will solve lot of your issues. And gut microbiota are changed when you increase your weight, and is also altered. It alters your immunity and also pathogenesis of several metabolic diseases, including your diabetes. So please include lots and lots of chas and dahi in your diet. So are we just talking about high fat and high fiber? No. We need to know that just after high fat diet, this gut microbiota is also altered, and thus leading to expansion of your microbiota, which is associated with lean phenotype, and you need to have this disruption of molecules as shown in this figure. So several studies have suggested that disruption of gut barrier function and gut microbiota derived LPS could contribute to the pathogenesis of metabolic syndrome, and therefore a low fat diet has to be eaten. What does the ICMR NIN says? You need to have 15% of your energy from essential fats, and visibly you can increase your fat to 50 grams a day if you are an athlete, if you are a real heavy worker. But for a normal person, 25 grams of visible fat, for pregnancy 30. So PUFAs 8 to 10% of your energy. Ideal quality of fat should have your good PUFA to SFA ratio. And how to maintain that ratio? I have just given some examples. You need to have rice, either groundnut or sesame or rice bran, a mixture of oil. For 2 or 3 oils should be there in your kitchen for various purpose, not a single oil consumption. And we had this paper jointly written by our group and Dr. Anup Mishra, led by Dr. Anup Mishra, which is for the dietary guidelines for the people with metabolic syndrome and obesity and diabetes, and also it limits that you should have 15% of your total energy from fat. This paper is freely available online, and all these guidelines are mentioned over there. But what I want to highlight is use more than one source of fat and oil in your kitchen, in your cooking, and additional way of increasing your ALA is to ensure regular consumption of foods. Now, what are these foods rich in ALA? For non-vegetarian, you have lots of fish, no problem. But for vegetarian, you need to have your nuts, your fiber-rich foods, your vitamin, and your green leafy vegetables. Now, if people don't like green leafy vegetables, please ensure that a bowl of chutney is consumed every day. Or I would also recommend pani puri ka pani as a starter to be given, because that is made from mint and coriander leaves. Okay? So these are some of the sources, and we need to know that there is very less study on the Perilla leaves, Perilla seeds, which are available in our northeast region, and I'm sure some of you sitting over here can then take up a long project on impact of Perilla seeds on the profile of, on the biochemical parameters of your diabetics. So enjoy the farsan in Gujarat, but beware that it may be of cottonseed oil. And if you want a lipid profile like this, after consuming all the farsan, you know where to contact. Thank you so much for your patient hearing.
Thank you, excellent talk. I would like to, one question that you are recommended blended oil or rotation of oil. Which is the better?
No, I have said that you need to have 2-3 oils in your kitchen. Say for example, for deep frying, you need to have oil with good smoke point. So if it is singtail, then for seasoning, you may have virgin olive oil or maybe tilka tel. Okay? For certain ingredients in the food item, you can have your ghee or some part of your saturated fat. But you need to have a good PUFA-MUFA ratio, basically. Not just one single oil in your kitchen.
I do also have one question. Nowadays, lot of people are using ghee cow ghee and ghee cow ghee and
ghee gai ka ghee.
yes.
Okay.
So, any comments or any insights on using ghee cow's ghee?
Okay. So the type or the quality of fat is definitely dependent on its origin. For example, if you are having cottonseed oil, you always have a risk of having that BT cotton inside you. Okay? So if you're having ghee from a good source, a confirmed source, okay, these are not hybrid cows, these are not Jersey cow, they are original, they are different breed, mixed, they are not mixed breed. So that's why they are promoting it. They're not saying it
Because
has a
they take
Videshi
so
angle.
much charge,
Yes,
around 100% difference in charges, and they
yes,
say if you take ghee cow ghee, you don't get heart attack.
You will definitely get a heart attack if you have more than required amount of fats in the body. That is why I showed you the first slide of metabolism, that irrespective of whichever type of fat you consume, if you consume more than the required amount, it is definitely going to settle in certain areas which are going to be harmful. Right?
Ma'am,
Okay.
I have a question. You have any clear-cut document and a presentation regarding with the cooked coconut oil? What I am asking, you mentioned about the coconut oil in Kerala. You know, after reducing the coconut oil in Kerala, the atherosclerosis and CVA incidents are increasing. Around 50 years and 70 years back, the incidence of all these CVA related problems are very less. So whether the study that happened on the the virgin coconut oil or the cooked coconut oil. Indians are not using the fresh coconut oil. We use, especially in South India, we use mainly the cooked coconut oil. Whether your study has got the virgin coconut oil or the pure coconut oil or cooked coconut oil.
Very good question, sir. Because there is a difference between the virgin and the refined coconut oil qualities. Now, several studies, if you look at the Coconut Board website, they will recommend coconut oil for heart. coconut oil is actually replacing many of the, it does have a property of lard as per the Harvard University professors. But if you look at the other studies by the Coconut Board, but then I see a conflict of interest in studies published by people who actually manufacture their own product. But your point is well taken, and maybe that is because of the impact of urbanization, industrialization, and also less agriculture or farming in Kerala some years ago as compared to now.
See, one more thing, Inas, who is basically from Kerala, gone to US and done a great, wonderful study. The study is especially promoting the palm oil.
Right.
Okay, then what he told, after consuming enough coconut oil, and his health is so quite good, and he told, coconut oils are not good.
No, sir.
See, the thing is that I think it is mostly on the reports coming, or vested interest may be there. That has to be taken in consideration, because I was in Coconut Board when we done the extensive study of coconut oil.
Sir,
nearly 25 years of study we have.
Yes, sir. So that is why I said if I look at the Coconut Board, I do get the whole answer as coconut oil is good. But then here we go by evidence-based trials, randomized control evidence-based trials. Okay, and the third parties randomized control trials have definitely said that coconut has high amount of saturated fat, and irrespective of whatever amount of saturated fat, if you restrict your consumption of coconut oil to 1 teaspoon a day, it doesn't matter, because you need to have 30 grams of visible fat every day. Of that, if you take 20 grams of any other oils with good PUFA-MUFA ratio and 10 gram of oil with your oil that's such as coconut oil or ghee, it doesn't matter, along with your regular physical activity. The heart, the health of the heart is not just dependent on what you eat. It also depends on the metabolism. It also depends on physical activity. It depends on many factors, sir. So if all these are controlled, and if a study is designed, that is going to be possible only in animals and not a clinical human trial.
Okay,
Yeah?
thank you. That's,
Okay,
I'm
thank
not
you, Anisha,
interested to
for
go into the
excellent
controversies.
talk. I would request Shruti to facilitate Dr. Vanisha. I request Dr. Deepak to facilitate our chairperson. Dr. Shruti. Dr. Minaz. Thank you very much.
For the next session, I would like to invite Dr. Chaya to moderate the session. Please, sir.
I'll invite Dr. Kirit Kubawat to chair this session, and Dr. Vidyut Shah. and Dr. Ranjan Dev. Please come on that. Okay, we are now heading to our next mixed bag session, and we have a first speaker, Dr. Sudhir Bhandari from Jaipur, and he is a MBBS MD medicine, and he has many publications, around 80 articles posted in medical journals. He has delivered more than 200 guest lectures at national and international conferences, and he is working at Dr. P.J. Mehta Young. He has also received P.J. Mehta Young Scientist Award, as well as he is having C.M. Raj Gaurav Award also. I had him this mic, and he will be talking on
peculiar infections in diabetes.
Peculiar infections.
Good afternoon. At the onset, I thank Dr. Bansi Sabu for having given this opportunity, and we are going to talk about a very interesting thing. Whenever we talk about the morbidity and mortality in diabetes, we concern ourselves to the micro and macrovascular complications, but today I'll be talking about how peculiar infections in diabetes, they take toll of patients. In fact, I'll be giving a brief outline to the pathophysiology of what happens in diabetes, how's the resistance come down, and what predisposes to the more infection complications. Little bit more about the diabetic foot infection, which is very specific and peculiar of diabetes, and then many of the uncommon infections. Although the overall the infection prevalence is very high. We have been talking about all these complications of diabetes, the standard complications, the ketoacidosis, hyperosmolar, non-ketotic coma, the micro and macrovascular complications. And one of the very important in the line of micro and macrovascular complications is the diabetic foot, along with the many peculiar infections. What exactly happens in the chronic hyperglycemia? There is an excessive formation of advanced glycation end products, there is activation of the protein kinase C, and there is an intracellular hyperglycemia with disturbance of polyol pathway. This is something very important which is happening in diabetic patients. This formation of advanced glycation end products involve intracellular glucose-derived dicarbonyl precursor combining with the amino group and leading to the formation of advanced glycation end product. This leads to the extracellular as well as circulating plasma effect, and this extracellular matrix protein which brings about the crossing between polypeptide, and it traps the LDL at the vessel and accelerates the atherosclerosis. Trapping albumin at the basement membrane thickens the basement membrane in diabetic glomerulopathy. At the same time, the circulating plasma protein binds to AGE receptor on the endothelial cells, mesangial cells in the macrophages, causing the release of cytokine, and intracellular vascular permeability increases and brings about the cascade of inflammation and predisposes to the setting of the infection. The activation of protein kinase, which stimulates de novo synthesis of diacetylglycerol, and this downstream effect of it are production of vascular endothelial growth factor, the increased vasoconstriction, increased deposition of extracellular matrix, basement membrane material, production of plasminogen activator inhibitor, and production of pro-inflammatory cytokine. So what predisposes to the excessive inflammation and vascular damage in case of type 2 or the type 1 diabetes? The polyol pathway, the glucose which gets into sorbitol and then to fructose, and disturbance in polyol pathways predisposes to the accumulation of sorbitol and fructose, increase intracellular osmolality, influx of water, and osmotic cell injury. There is a NADPH used up during the polyol pathway, and there is more of oxidative stress cellular injury which predisposes to the infection. So if you look at this, especially we will be talking to begin with diabetic foot ulcer is a combination of peripheral vascular disease and peripheral neuropathy, immunocompromised, and infection is there. Other factors have been identified such as repetitive stress, pressure on insensitive feet, poor glycemic control, and others which has been talked about. All This, in addition to many infections, are more common in diabetic patients. There is an increased severity and increases of complication because of immunocompromised state. The suppressed immunity in diabetic patient is coupled up with polymorphonuclear cell function depression, particularly when acidosis is present. The leukocyte adherence goes down, chemostaxis goes down, phagocytosis goes down, and antioxidant activities goes down. That's all is happening in case of acidotic diabetic status. But response to the vaccine appears to be normal. That's the reason when diabetic patients are adequately covered by the vaccination, we have the adequate protection. Improving glycemic control might improve the immune function, and that's very important. Many of the studies have confirmed that hyperglycemia associated with increased infection and mortality, which is proved beyond doubt, various kind of nosocomial, surgical site, etc. And it has been proved beyond doubt that good glycemic control decreases wound infection rate in many of the studies. So hyperglycemia predisposing and good glycemic control bringing down the infection rate. Let's begin with the diabetic foot infection, which is very peculiar to the diabetic patient. Many common in men with the diabetes more than 10 years. Poor glycemic control is a prerequisite. By the time the patient has associated CVS, retinal and renal complication, which is very important. Various pathogenesis has been talked about. The neuropathy, the sensory neuropathy, which decreases the awareness of injury to the foot. The motor neuropathy, intrinsic muscles of the foot, foot deformity and maldistribution of weight, which causes a pressure sores. The autonomous neuropathy, which decreases sweating, dry and crackled skin, breaches in the integrity of skin, and entry of microorganisms which predisposes to the infection. Superficial fungal infections are very common. The high rate of nasal and skin colonization with Staph aureus is known beyond doubt. Vasculopathy and defects in immunity, which impairs the wound healing, which also is an integral part of the diabetic patient. When we talk about it, how do we diagnose? Difficult to differentiate infectious versus non-infectious osteopathy. Soft tissue infections alone versus soft tissue infections with osteomyelitis. Most patients with diabetic foot infections are afebrile and have absence of local inflammatory sign. 1/3 of diabetic patients with foot infection are found to have evidence of osteomyelitis. In patients with osteomyelitis, the cumulative amputation rate over 1 to 3 years is almost 40%. The diagnostic clues of underlying osteomyelitis is when the ulcer area is more than 2 centimeters square with a sensitivity of 56% and specificity of 92%. Deeper ulcers, more than 3 millimeter we have. All exposed bones has underlying osteomyelitis. The probe to bone test, that is positive predictive value of 89% and negative predictive value of 56%. Some patients' condition may appear less serious or more superficial at the presentation than they are found at surgical exploration. We need to have all these supportive evidences to confirm the status of infection. Simply swabbing of the overlying ulcer often yields organisms that are colonizer and not actually the causative agents. Specimens from the deep tissues of the bone increases the likelihood of isolating true pathogens, and there are a lot of studies have depicted the nature of the infection which we come across. Deep diabetic foot infection is a classical polymicrobial infection and anaerobic infection. There's an important thing, it is mainly polymicrobial and anaerobic. The conditions with the chronic ischemic tissue favors the growth of obligate anaerobic bacteria, the permitting synergistic interaction with facultative bacteria, and augments the overall microbial virulence of infection process. The antimicrobial therapy should receive therapy effective against Staph aureus and other aerobic gram-positive cocci. Expanding therapy to cover aerobic gram-negative bacilli, anaerobic organisms in patients with deep infections, and we have various these combinations available which has been mentioned, and we can opt for them. If infected bone can be easily dissected without compromising the integrity of foot, this is preferably to the prolonged antibiotic therapy. The source of infection is taken care of. When the infection involves a digit, especially other than the grade 2, amputation may be the most cost-effective approach. We need to be very careful about it. Aggressive surgical approach at times we need to be opting for. 76 out of 86 patients with infection involving the phalanges or metatarsal heads were cured by combined limited surgery, for example the resection of a toe or ray, or a transmetatarsal amputation and antibiotic therapy. allowed antibiotic therapy to be limited to an average of only 2 weeks. So cut short the duration of antibiotic therapy if osteomyelitis portion is taken care of. Early surgical intervention takes good care in case of osteomyelitis patient. So the sixth principle of preventing a very peculiar diabetic foot ulcer, we need to have a very good podiatric care, the pulse examination, the protective shoes, pressure reduction, prophylactic surgery, and patient education, which is very important. Then we have the plethora of other infections which are very common in diabetic patient, which are little more peculiar than rest of the patient. The respiratory tract infections. Diabetes is not a significant independent risk factor for death in elderly with pneumonia, but there is an increased frequency with the infection caused by Staph aureus, GNB, and PTB, increased bacteremia and mortality in patients with pneumococcal pneumonia, increased mortality and incidence of bacterial pneumonia during epidemics of influenza. Influenza and pneumococcal vaccine should be considered for diabetic patients, as I talked that immunity or immune response remains preserved in diabetic patient. The urinary tract infection, it could be symptomatic urinary tract infection or asymptomatic bacteriuria, which may be there. The clinical features, diagnosis and treatment of uncomplicated urinary tract infection in diabetics are same as for non-diabetics. The rare emphysematous urinary tract infection, which is pyelonephritis, pyelitis, or cystitis, more than 90% occurs in diabetic patients. Gas formation seen in plain X-ray or the CT, antibiotics plus open drainage and nephrectomy has been taken into consideration. Overall mortality rate was almost 18.8% in emphysematous urinary tract infection, which can be picked up on the X-ray and the CT scan. Same pathogens as non-diabetic like E. coli is commonest pathogen, Klebsiella pneumoniae, GPB, Streptococci, and C. albicans are the most common in diabetic patient, which is very important. Distribution of bacterial isolates in urine from 2004 to the May 2006 has been found that E. coli leads the spectrum of the various infections which we come across. The choice of antibiotics, these are the various choice of antibiotics we have been commonly using, which we need to use for little longer time. Another very important thing is that the risk factors, longer the duration of diabetes, greater are the chances, greater the microalbuminuria, non-circumscribed partners, and there is no association with current HbA1c level or glucose control. So greater the risk factor, greater will be the chances of asymptomatic urinary tract infection. It is more common in diabetic women but not in men, more likely to develop symptomatic UTI in asymptomatic bacteriuric patients, does not have increased risk of faster decline in long-term renal function. Antibiotic uses in case of asymptomatic urinary tract infection not affect the frequency or the time to symptomatic infection, including pyelonephritis. Recurrent asymptomatic bacteriuria is treating group is common. Antibiotic related adverse effects we need to consider, and associated with resistance development, we need to be very careful about it. So once we talked about the asymptomatic urinary tract infection in diabetics, which is very common in women, the another very common infection in the diabetics is the folliculitis. This is infection of hair follicle. The risk factors are exfoliation of skin, damage hair follicle, shaving, use of Lufan sponge, Staph aureus and Staph epidermiditis are the common agents which we have. Furuncle, the skin disease caused by the inflammation of hair follicle, thus resulting in the localized accumulation of pus and dead tissue. Common bacterial infection as Staph aureus and Staph epidermiditis. Carbuncle, the collection of multiple furuncle characterized by red, hot, painful nodules that often drain pus through the multiple openings of the skin, usually extends into the deeper layers of skin. The subcutaneous fat tends to occur in the areas with thicker skin like the nape of the neck and back or the thighs. So this is another very common infection which may come across in the diabetic patient. Cellulitis, acute spreading inflammation involving the epidermis, dermis and subcutaneous fat is one of the very common concomitant infection so far ignored in diabetic patient. Often occurs when the skin has previously been broken, cracked, cuts or blisters or burns, insect bites are there, and surgical wounds or site of the IV catheter insertion can be caused by normal skin flora or by exogenous bacteria. The crepitant anaerobic cellulitis appears as a necrotic soft tissue infection with abundant connective tissue gas. characterized by gradual onset absence of muscle involvement, lack of marked systemic toxicity. So we need to be very careful about gas-forming infections also, and this is the way dermal cellulitis we may come across. The causative organs are again strep and strep pyogens. Occasionally streptococci from other groups like B, C and G can also cause. Majority of cellulitis, facial cellulitis in childhood are caused by Staphylococcus aureus, less commonly by Haemophilus influenza type B, but they rarely cause cellulitis in adult. So children more common to have Haemophilus influenza. This is one of the very important happening in the diabetic patient we need to be very careful about. Necrotizing fasciitis is an infection of subcutaneous tissue and fascia characterized by progressive necrosis, rare infection with high mortality, almost 30 to 40%. Clinical manifestations include necrosis of the superficial and often deep fascia, and these necrotizing fasciitis of two types. Type 1, the polymicrobial form, mixed infection of anaerobic and aerobic bacteria. The type 2 is monomicrobial, aerobic organism, especially strep pyogenes, Staph aureus, and members of E. coli and Enterobacteriaceae. Anaerobic organisms, the Peptostreptococcus, bacteroids, and Fucibacterium are also there. The clinical features are, initially it begins as a cellulitis with the advanced slowly redness, edema, pain, and very tender and warm. Over the next 2 to 4 days, skin changing from red to purple to pathognomonic gray, blue with ill-defined patches, hemorrhagic bully may develop, and necrosis of superficial fascia and dishwater pus discharge. Systemic toxicity develop, high-grade fever, chills and malaise, tachycardia, generalized toxicity and septic shock. We need to be very careful about necrotizing fasciitis. Failure to respond to initial antibiotic therapy, little improvement even on therapy, and woody hard feel of subcutaneous tissue extending beyond the skin involvement, systemic toxicity often with altered mental status, and this we need to be very careful of necrotizing fasciitis at the present, rapid progression even after 24 hours, so we need to be very careful how it goes deeper to the muscle and patient start developing the toxic symptom. Another very peculiar infection in diabetics, which I just finished within 2 minutes, the gas gangrene, which is by the Clostridium group of organism, which may have the blisters, and these kind of the blisters with the crepitations and gas bubbles seen on the X-ray in a diabetic patient. You need to be very careful of Clostridium kind of infection. Plain X-ray may show the gas bubbles, which we need to be very careful about it. There is a difference in the ischemic and the neuropathic ulcers, which I talked about. This just, I'll take 1 more minute. The ischemic foot ulcer, the dorsum of second toe shows ischemic lesion, whitish color on the tip of the ischemia, and look at this neuropathic foot ulcer. What a difference in the presentation. Look at that. This is the ischemic or the vascular ulcer. This is the neuropathic foot ulcer, which will might develop the secondary infection on the first metatarsal head. Because of the neuropathy, there is a atrophy of the muscles and the maldistribution of the weight-bearing areas. Mixed etiology may have the wet as well as this ulcer. The gangrene ultimately can develop, which may have across. And I'll just quickly show you what are the another quick newer the thing. There are certain head and neck infections which are peculiar to diabetes. These are malignant otitis media. This can get into temporal bone, parotid space, nasopharyngeal and masticular space. You need to be very careful. Posteriorly, it may go into the mastoid process, anteriorly into the temporomandibular joint, medially into the petrous bone. Then mucormycosis, one of the very peculiar infections in diabetic patient, is an aggressive opportunistic infection caused by fungi. In individuals who are immunocompromised, germination and hyphae formation occurs, and this allows the organisms to invade the patient's blood vessels. Extension of mucormycosis can to the various parts of the brain, pterygopalatine fossa extension, intraorbital extension, intracranial extension, cavernous sinus thrombosis, which can happen with this. Other fungal infections like sinus aspergillosis can happen. The orbital infections are also very common with the fungal infections. Subperiosteal abscesses could be there, which can involve the various parts of orbit. Chest infections, the aspergillosis is very prone to happen in diabetic patient. We may have the different type of aspergillosis which may come across. Invasive aspergillosis with air crescent sign, semi-invasive aspergillosis we can have. We can have the abdominal infection. I just one word I'll speak about the emphysematous cholecystitis, which is very common. Emphysematous pyelonephritis, which is very common. Emphysematous cystitis is very common. Gentogranulomatous pyelonephritis, which is very unique to the diabetes. Fournier's gangrene, a polymicrobial necrotizing fasciitis of the perineal the perirectal and genital area, which is quite common in diabetic patient, we need to be very careful about it. And these are the various evidence. So if we conclude, the infections in diabetic patients have many specific consideration in their diagnosis. Their extension increase the seriousness of condition. The potential lethal outcome of these cases must prompt a rapid and accurate diagnosis. So we need to think beyond the simple infection than rarer, peculiar infection of the diabetic patients. Thank you very much.
Thank you, Dr. Sudhir. It was a lucid talk. You have covered almost so many things. And yes, we need to know about foreigners gamins 2, which is now going to be seen in some more number if we are using SGLT2 in our patients. So it's a good talk. Thank you. I'll ask Dr. Vidyut to felicitate. I'm skipping question answer session. We are a bit short. Dr. Vidyut to felicitate. Each talk is of 15 minutes, so please set timer for 15 minutes. Now I invite Dr. Sambit Das to have his next lecture.
Hello, good afternoon, everybody. Dr. Sambit Das is an adjunct AP of endocrinology, EHERF. He has got publications in national and international journals. He is into phase 3 clinical trials, and he was a past General Secretary of Endocrine Society of Odisha. Sir is going to speak on new clusters of diabetes, relevance in Indian setting. Please, sir.
Thank you, sir. Respected chairpersons, distinguished doctors present here, very good afternoon to all of you. Now, the topic which I will be discussing is new clusters of diabetes and relevance in Indian setting. It's a difficult topic because the classification is now changing, and what is the new concept of that I will be discussing in this agenda. Like, what are the different ways of classifying diabetes? Data-driven cluster model for diabetes, what is the new concept of clustering of diabetes, and what is the relevance in Indian setup. So coming to the first part, that is how we actually classify the diabetes in a different ways. Now it would be too unethical if I don't tell or mention the name of Sir Harold himself, who is actually the first person who has systematically tried to classify the diabetes into an insulin sensitive and an insulin non-sensitive diabetes way back in 1936. And following that, there were many effort to classify diabetes, but in 1997 I think we came to a conclusion with the ADA that diabetes can be classified into almost 4 types, like type 1 diabetes, type 2 diabetes, other specific types, and gestational diabetes. And till now we are almost following this type of classification. But there are certain problems with this classification because it depends on age of onset and insulin dependence mostly, cannot predict the complication. By classifying the diabetes type 1, type 2, GDM, we cannot actually predict what the complication the person can have, cannot predict the suited treatment modalities because we lack the precision of medicine over there, and many atypical diabetes were not included, like Flatbush diabetes, LADA and all, many were not included in this group of classification. So in 2016, Stanley et al. Have tried to again reclassify the diabetes basing on the concept of beta cell centric mode of classification schema. And what they proposed is that diabetes, the ultimate final common pathway or the denominator is beta cell secretion. The genes can play directly to produce insulin resistance or can lead to beta cell dysfunction. And the environment, inflammation and the immunoregulation will actually lead to insulin resistance and beta cell dysfunction together. But it's the final common pathway is the beta cell dysfunction because it determines whether its beta cell is still capable of coping or it is completely exhausted. So that's the spectrum of diabetes depending on the beta cell model. There was another group of people who have tried to classify the diabetes depending on the artificial neural networks. This is basically a type of artificial intelligence where there was a pattern recognition, signal processing and medical diagnosis. and it required a complete set of data from the accurate classification. And a classifier was applied to PIMA Indian diabetes dataset, and the results were improved tremendously in using certain combination of pre-processing techniques. So they have taken almost 8 pre-processing units. They've taken all the data from the patients. With an artificial intelligence, they could find the pattern of the different types of diabetes, and then they have classified, and that they've shown to be almost 90% accurate in classifying the proper diabetes, and this is the article in favor of that. Now coming to the proper way of the new type of classification which has been recently published, that is the data-driven cluster model of diabetes. And what is that? It is actually EMA et al. In 2018 have tried to classify the diabetes in the different clusters, and this is the cluster analysis by 6 variables. It's a novel diabetes classification based on data-driven cluster analysis of 6 commonly measured variables. 4 cohorts of Sweden and Finland were involved in that. And the 6 variables that they have taken into account is age of onset of diabetes, BMI, HOMA-IR, which is a measure of insulin resistance, HOMA-beta, which is a measure of beta cell function, GAD antibody status, and the genetic loci. So these are the 6 parameters that took to classify the diabetes into different clusters. And what they found out was that there were almost 5 clusters of diabetes was there. The first cluster was severe autoimmune diabetes, they call it as SAID, was genetically associated with variant of the HLA locus that is most common in type 1 diabetes, and this group of clusters are associated with GAD antibody positive. The second cluster is known as the severe insulin deficient diabetes, that is SIDD, and included a GAD antibody negative patient and the lowest HOMA2B score of all the cluster, and showed no association with the HLA which were associated with type 1. But despite the absence of GAD antibody in the second cluster, both the first cluster and the second cluster, that is the severe autoimmune diabetes and severe immunodeficient diabetes, have many features in common. That is, they have low BMI, insulin deficiency, high HbA1c concentration at diagnosis, poor glycemic control throughout the course, and when they were treated with OAD, usually they didn't respond. So these were the common features between the SAID or the SIDD, the first 2 clusters of diabetes. Now the third cluster they have told as severe insulin resistant diabetes, and these patients had a mean age of around 65 years at diagnosis with a higher HOMA-beta and HOMA-IR. The HOMA-IR is too high, depicting that the insulin resistance is the predominant feature in this cluster of diabetes. And the fourth cluster is mild obesity related diabetes, is characterized by mostly obesity, and the cluster 5 is mild age related diabetes, is characterized by increased age at diagnosis. So these were the 5 clusters that have been proposed by Emma et al. From their cluster analysis, and patients in the cluster 4 and cluster 5 were the highest group of population, and they have relatively milder and better controlled diabetes than the patient with actually severe autoimmune diabetes or severe insulin deficient diabetes, and developed renal and vascular complication at a slower rate. So the cluster 4 and cluster 5 were relatively a better variety of diabetes compared to cluster 1, 2 and 3. So this is how the cohort actually looked like. If we go by the conventional classification, then the upper pie chart will tell that almost type 2 diabetes is 93%, LADA was almost 5.2%, and type 1 diabetes was 1.2% in that Finnish cohort. But when they did a cluster analysis, they could find that there were 5 types of diabetes actually present in that cohort. But the best and the most beautiful part of this cluster type of classification is that the time to chronic kidney disease. They found that the cluster 3, which is associated with high insulin resistance, is in fact associated with highest incidence of chronic kidney disease during the 8 to 10 years follow-up. So that is one of the most striking feature of this type of classification. And similarly, the diabetic retinopathy, in that cohort they found that the cluster 1 and cluster 2, which were severe autoimmune diabetes and severe insulin deficient diabetes, had more chances of diabetic retinopathy compared to other forms of diabetes, other clusters of diabetes. And the cluster characteristics, when they could compare the different types of variables, if we see the HbA1c variable, then probably the cluster 1 and 2 had poor HbA1c compared to the other clusters. If we see the second part, that is the BMI, then the cluster 4, the cluster 5 and the cluster 3 had the highest BMI. If we see the age, then cluster 5 is the highest age among them. HOMA 2 beta, that is the insulin secretion, is the lowest in cluster 1 and 2 because they are insulin deficient. And HOMA IR, which is the sign of insulin resistance, was highest with the cluster 3 according to the variables and their clustering. If we see the mean HbA1c over time in all the new diabetics, what they found was that cluster 1 and 2, which was severe, which were autoimmune diabetes or insulin deficient diabetes, had throughout the course had poor glycemic control compared to the cluster 4 and 5. So they showed that those who were insulin deficient had poor glycemic control. In genetic analysis, though they could not find a clear-cut association with different clusters, but they could find one genetic loci, that is TM6SF2, which is associated with non-alcoholic fatty liver disease, have been clearly more common with insulin resistance type of cluster, that is the cluster 3. So cluster 3 has been associated more with non-alcoholic fatty liver disease. So in that cohort, they could find that almost 40% of the patient had actually the MARD variety of clustering, and the obesity related is 21.6%. The severe insulin deficient diabetes was 17.5%, severe autoimmune diabetes was 6.4%, and severe insulin resistance was found in 15.3%. So these were the 5 type of clusters they found in that cohort of Sweden and Finland. So now there is a transition. Suppose if we classify diabetes as per the previous definition, we have type 1, type 2 and LADA, but if we see the future classification or the classification by the recent article, then there are almost 5 types of clustering of the diabetes is there. But that was about that particular article, and IMA has clearly mentioned that this new sub-stratification could change the way we think about diabetes, because we tailor and target an early treatment who actually respond to the treatment first and predict the complication from the very beginning. We can actually tell which complication will come in which type of diabetes, and thereby it's a first step towards precision of diabetes in precision medicine in diabetes. Precision medicine means we know from the very beginning who are the people who will respond to this class of drug, who are the people who will respond to that type of drug. So we start from the very beginning that type of therapy. So this is the first step towards precision of medicine. But there are some drawbacks to that, and how relevant that is in Indian context is more important, because Indians are different. We have high prevalence of diabetes, high prevalence of pre-diabetes, but the third point is most important because it's the highest global rate of pre-diabetes progression to diabetes, almost 18% per year of the transition from pre-diabetes to diabetes. And diabetes onset is almost 2 decades earlier in our population compared to the Western population, highlighting that our population has got a aggressive phenotype compared to the Western, and we know the concept of thin fat Indians. So these are the few things we need to remember while classifying that cluster classification to our Indian population. There's a very nice letter to editor by Deep Datta and Satyanath Mukhopadhyay et al. In the Lancet, in the same Lancet where the previous article was published, and they found 5 limitations with that classification, which is not good for Indians. The first limitation was that the cluster could detect who is going to progress to kidney disease, who is going to progress to retinopathy. But the most important thing is that the cluster could not find out high risk of cardiovascular event, which cluster is going to progress, and that is the most important part in our setup also. The second limitation is that it doesn't account into fibrocalculous pancreatic disease or Flatbush type of diabetes, which is relatively prevalent in this group of population, and drug-induced diabetes and genetic forms of diabetes would spread out heterogeneously among the different clusters. The third limitation is that, and it's the major limitation of the new classification, is that they need to measure GAD antibody and C-peptide to classify the patients into different clusters. And how many of us actually do GAD antibody or the C-peptide assay? It's expensive, not widely available, and not well standardized, especially in developing countries like India. So probably doing all the 5 tests in a diabetic patient would be too expensive to classify the patient into diabetes, in different clusters of diabetes. And final point is it worth doing this cluster analysis in Indian setup? Now in that Andes cohort, in that Swedish cohort itself, they found that 575 patients had type 1 diabetes or LADA using the traditional classification. But using the newer classification by the Anne et al., they could find 577 patients were labeled as having severe autoimmune diabetes. Hence only 2 patients were actually reclassified, a very small number considering the cost involved with the new classification system. So we should actually take it with a pinch of salt before going for a full classification on the cluster-based analysis. So with that, I will conclude that the new cluster system of classifying diabetes is definitely a step forward in precision medicine of diabetes, but applicability in Indian scenario is debatable and requires more studies in Indian phenotypes. Thank you for the patient hearing.
Thank you so much, Dr. Das. I think you would try to simplify the very, very complicated topic. Down the lines, maybe after many years, it would be useful, but as you said, the cost is very high at present. So very nice topic. Thank you so much.
Thank you.
For Indian patients, we can do clinically also.
Yeah,
I was just talking to the Ranjit. May not be necessary that each and every patient we have to go for C-peptide and get autoantibody, because that we can decide with some of the lean patients or the patients where you are thinking that they are insulin deficient. Other than that, most of the patients may not require C-peptide and get autoantibody test, which is more costlier than other tests can be done. So I mean, clinically we can start thinking our own patients. And the most important thing, there are some patients who are more prone to develop microvascular complication, nephropathy in this particular classification. That we must see in Indian subset what exactly happens to those type of patients who are obese or who are having high insulin resistance, whether they develop more of a CVD or more of a renal dysfunction. That we must see in our Indian patients also.
Very correct, sir. I think we should first phenotypically and clinically classify, and then only lean diabetes or where there is a confusion, we can go for C-peptide and GAD antibody. So that should be the take-home message. Thank you.
Right, sir. Since we are running short of time, I think we'll have the question-answer sessions at the end of the session.
Thank
you, sir.
Thank you. I'll ask Dr. Vidyut to felicitate Dr. Samit Das. Sir, Samit Das. Now we have the next speaker. He is going to talk about the lipids and neurofrontier and lipid management. We know about the first and second the lipid guidelines of India. What next is coming, I think Dr. Raman Puri will definitely let us know. And let me give his brief introduction. He is a cardiologist at Delhi. He is a head of department at Subjanjik Hospital as well as RML Hospital. And he is one of the founder member in our Lipidology Association and giving our guidelines. Over.
Good afternoon, everybody, and respected chairperson, and special thank to Dr. Bansi for giving me an opportunity to be here in this what a well-organized conference which I have seen. Thank you very much once again. So I am going to discuss about newer frontiers in lipid management. We all know that cardiovascular disease is a global problem. More than 415 million patients there in globally, and about 18 million died in 2015. And LDL cholesterol is no more a surrogate marker. It's causally related to coronary artery disease and CVD. Statin is most important drug. And regarding LDL cholesterol, we still don't know what is the lowest goal we should try to achieve. And we all know that triglyceride is also responsible for increase in CVD risk. And regarding HDL, there are a number of controversies. At present, it is not considered as a treatment strategy. And one most important thing is that inflammation has been pointed out to be one of the risk factors in pathogenesis and acceleration of atherosclerosis. So the real challenge is residual risk. You know, how to reduce risk of future cardiovascular event despite controlling all these parameters which I have discussed. And there are four main areas where we can concentrate. One is that we bring down LDL cholesterol lower and lower and lower. What exactly the lowest level, we don't know. But at least if we follow a lipid association guideline, where we have said we're the first country in the world to recommend less than 50 as the goal in patients with high risk group. If at least we achieve less than 50 milligram, that will definitely reduce residual risk. And triglyceride reduction, so far we have not shown any outcome data that they really benefit in reducing triglyceride. And another issue is, should we reduce lipoprotein small a, because as an Asian we have higher prevalence of lipoprotein A, and it has been said to be responsible for increased prevalence of coronary artery disease in our country. And of course, after taking care of all these things, if we reduce inflammation, like shown in Jupiter trial and CANTOS trial, can we reduce cardiovascular even further? And we do not have any definite answer to HDL. Now, these are some of the modalities of lowering LDL cholesterol: PCSK9 inhibitors, monoclonal antibodies, and small interfering RNA, PCSK9 vaccine, MTP inhibitor, LDL receptor gene therapy, and mipomersen. Mipomersen is off the market now. Manufacturing has been stopped because FDA has removed that clearance for using this drug for homozygous familial hypercholesterolemia. Now, I'll shortly discuss about PCSK9 because you are all aware of this, that presence of PCSK9 in circulation binds with LDL receptors, and it breaks down LDL receptors within the hepatocytes. So as a result of this, if you have high PCSK9, there will be very less receptor on hepatic surface, and as a result of this, LDL cholesterol will go up. So with this point, I am going to present you 3 slides, which will give you the conclusion of this PCSK9 and LDL cholesterol. One is the Fourier trial. This was in 27,000 patients with stable coronary artery disease. They were high risk group because they have associated hypertension and diabetes also. And in this study, it was found that there was a significant benefit in reduction in cardiovascular event at a level of ultra low LDL cholesterol. Ultra low means there were about 2% of these patients, about 504 patients, who had an LDL cholesterol less than 10 milligram, mean of 7 milligram. So there was a benefit extended up to 7 milligram of LDL cholesterol with no adverse effect due to PCSK9, nor there was any adverse effect because of lower LDL cholesterol. Duration of this was for about 2 years. So we do require 10 years assessment to come out strongly whether that they are going to be safe or not. 2 years is too short, but so far it has shown that. Then there was another trial, GLAVGO trial. This was an imaging trial in which we did intravascular ultrasound at the beginning of the study and the end of the study. We were fortunate to have 2 years follow-up, 18 months follow-up of intravascular ultrasound at different level of LDL cholesterol. Now, we had evidence at 93. There was increase in percent atheroma volume, very insignificant increase. Then at 70 milligram, there was slight reduction in percent atheroma volume. When LDL came down to 36, the percent atheroma volume came down to 0.95%, and at 25 milligram, it was 1.97. Shows lowering LDL cholesterol and keeping at this level. Not only, changed what we saw in Fourier trial, that it reduced events, but it showed that there was regression in the atheroma. So with the lower LDL cholesterol, we have both evidence of event reduction and regression in atheroma. Then we had Odyssey trial, which was published last year. Unfortunately, it has not been published in journal, reasons which you don't know. But it has shown again that lowering LDL cholesterol does reduces events. But it gave us some other information in a way that in a subgroup analysis, it was found that if your basal LDL cholesterol was more than 100 milligram, the reduction in event was more as compared to a lower value of basal LDL cholesterol. Now, so PCSK9 is a validated target for reducing LDL cholesterol, except that it requires 12 to 24 injections per year. So adherence may be a problem, but not that problem as we have patients on statin therapy. And this adherence is important because in patients with extremely high risk group, we cannot take chance of variability of LDL cholesterol during the treatment. Now came the concept of small interfering RNA. See, for every PCSK9 is genetically controlled. There is a genome which makes messenger RNA. This messenger RNA makes PCSK9. So if I destroy or break this messenger RNA by a recombinant messenger RNA which binds with this messenger RNA, and with the help of slicer or dicer, you cut this messenger RNA, so there is no messenger RNA, so this means no PCSK9 will be produced. This is the basic mechanism of small interfering RNA. Why it was important? Because when you give PCSK9 inhibitor, subcutaneously, it only blocks the circulating, PCSK9, but that amount of PCSK9 which is within hepatocyte and which also contribute to the LDL receptor destruction, it has no influence in that. So this recombinant PCSK9 small interfering RNA will, it will help in reducing this destruction also, which happens in intrahepatic. We have Orient trial in which inclisiran was given, and this was basically objective was to evaluate optimal dosing, what should be the optimal dose, and it was seen that if you give one injection on day 1, there is a significant reduction in LDL cholesterol at day 90, but after that the benefit goes off. And at the end of 9 months, it comes back to around 40%. If I give another injection at day 90, this benefit remains up to 6 months to a level of about 60%. If you look into the benefit of LDL cholesterol reduction at 6 months and 7 months, you see that at 6 months there is 64% mean LDL cholesterol reduction, and its benefit comes down slightly at 58.9 at the end of 7 months. So the conclusion of Orient trial 1 was that at 6 months time, the mean LDL cholesterol reduced to 52.6%, around 64 milligram. Something which I have seen, I tried to find out what was the benefit of statin versus Fourier trial and all that. I find that statin also reduces LDL cholesterol with high intensity statin, around 60 milligram. And that is what you achieve with PCSK9 also. Because, and this is useful for us, means if you reduce 60 milligram of LDL cholesterol with high intensity, which has a different mode of action, and another 60 milligram with, 60% with the PCSK9, this benefit will be definitely augmented. So benefit of this small interfering RNA therapy is that it's almost 2 or 3 injections in a year which you have to give. So adherence is, is not a problem. And second is this, that injection variability comes down of LDL cholesterol. The number of trials after these positive results, and the Orient 4 trial is a cardiovascular outcome trial in 15,000 patients with stable coronary artery disease. Now coming to MTP inhibitor, its mode of action is very clear. It prevents the binding of ApoB with triglyceride. So if it prevents this binding at liver, it will reduce VLDL, and if it prevents this binding at the level of intestine, it will reduce chylomicron. So this means it is a drug which will reduce both VLDL and chylomicron. So if they reduce both, what will happen? The triglyceride will accumulate in the liver, and so will the triglyceride accumulate in the intestine wall. So they have more of hepatic side effects and the gastrointestinal side effects. So there has been only one trial on homozygous trial in which it has shown that it reduces LDL cholesterol by 50%, and in one of the case it has shown chylomicron coming down from 3,500 to less than 500 milligram. And it has been put in the guideline of NICE. They say that it should be used in a patient in which you have no other alternative, and in place of lipid apheresis also, or along with lipid apheresis, lomitafide can be used. Now coming to the triglyceride, this is again very important for us. I will concentrate on ApoC3 and angiopoietin-like 3 or 4. See, the VLDL changes to intermediate density lipoprotein by losing triglyceride, and this is by lipoprotein lipase. So if this enzyme is deficient, the triglyceride will go up, and if this lipoprotein lipase is effective, the triglyceride will come down. So we have to see that what are the factors which inhibits lipoprotein lipase and what are the factors which have a positive effect on lipoprotein lipase. ApoC3 and angiopoietin 3 inhibits lipoprotein lipase. And APO5 has a positive response to lipoprotein A. So if we modify these drugs with antisense agents, we are going to definitely reduce triglyceride, because if I inhibit ApoC3 and inhibit angiopoietin 3, the lipoprotein activity will go up. So that is the basic mechanism by which these drugs act. So these are some of the drugs which has been used. Volanisorsen was a drug which was used for this familial hypercholesterolemia, but unfortunately this drug has been not approved by FDA recently, and this has a lot of controversy why it has not been accepted for using this patient in familial hypercholesterolemia. And coming to these two trials, REDUCE-IT trial and STRENGTH trial, these are omega fatty acid trial, these are cardiovascular outcome trial, and one of the trial results is expected in December 2017, and if it becomes positive, then this will be a better drug for us in reducing triglyceride. And coming to CANTOS trial, this is a canakumab trial. It has been found that those patients in which you achieve target, and if high sensitive CRP is more than 2, then if you give this patient a dose of 300 milligram of canakumab subcutaneously, on those patients with LDL cholesterol in normal range, what happens? It reduces major adverse effect by more than 15%. And the major adverse effects the events are reduced much significantly in those patients in which high sensitive CRP comes down below 2 milligram. So a single injection of canakumab can tell you whether you require subsequent injections or not. So if there is a significant reduction in high sensitive CRP, give it, continue it, and otherwise stop it. And it reduces malignancy incidence significantly, so there are other plus points. So I will summarize that new drugs are effective in reducing cardiovascular events. Lowering LDL cholesterol to ultra low levels shows not only reduction in cardiovascular event, but also decrease in percent trauma volume. Small interfering RNA therapy will reduce number of injections with LDL cholesterol reduction comparable to PCSK9 inhibitor. Gene therapy I have not talked about, but it will be very useful for homozygous familial hypercholesterolemia. We are waiting for cardiovascular outcome trial results from REDUCE trial, and if it is announced that it's positive, it will be a good drug for us. And residual risk of coronary event can be further reduced by achieving LDL cholesterol less than 50 milligram in high risk, as we have recommended 2.5 years back. And if still you have a problem, look for triglyceride and non-HDL cholesterol, and even still there is high, you can add canakumab if it is available in near future. And we have encouraging result for lipoprotein A by using antisense agent. I think that will be another drug which will come in the limelight in next few years, but there is no evidence of severe reduction in increasing HDL cholesterol. Thank you very much.
Thank you, Dr. Raman. It was a nice, knowledgeable talk. I'll ask Dr. Ranjan to felicitate Dr. Raman. We'll have a question answer after the next.
The next speaker is Dr. S.N. Narsingan from Chennai. He is Managing Director, SNN Diagnostic Center, Chennai, and he has published 53 articles in prestigious medical journals, and he is Vice Chairman of Lipid Association India, and he has received many awards in his illustrious career. Dr. S.N. Narsingan will speak on recent hypertension guideline, confusion or clarity. Over to Dr. S.N. Narsingan.
Thank you, Chairpersons. Good afternoon, everyone. At the outset, let me thank Dr. Bansi Saboo for giving me this excellent opportunity to be here in Ahmedabad. The topic is on recent hypertension guidelines. Many of you would have come to know by this time that last year we had witnessed the publication of ACC-AHA guidelines in 2017 November. This year in the month of June, we witnessed the publication of ESC-ESH guidelines on the management of hypertension. Are we getting confusion because of this publication of the guidelines? Or is there any clarity in dissecting out all these guidelines? Let me try to spend some time on these issues. Hypertension is the most common condition seen in primary care. It leads to myocardial infarction, stroke, renal failure, atrial fibrillation, peripheral artery disease, and then the aortic dissection, dementia are not uncommon complications. Death occurs if not detected early and treated appropriately. It not only increases the morbidity, but also premature mortality is the most common problem that is encountered in uncontrolled hypertension. The worldwide prevalence, as per the recent data, exceeded nearly 1.13 billion, and the average prevalence in India is estimated to be around 25%, involving 250 million people with hypertension. Having seen this, let me now take you to this guideline which was published last year. About 9 organizations actually joined hands with the ACC-AHA and came out to this recommendation last year. Let me now try to tell you about the goal which was recommended by ACC-AHA. It should be around 130 systolic blood pressure. If you recollect the data which was published in the academic bodies, the JNC 4 and 5 insisted on 160 systolic blood pressure. It was brought down to 150 in JNC 6, but JNC 7, which was very, very popular among ourselves, I think it was brought down to the levels of 140, endorsed by the International Society of Hypertension as well as the American Society of Hypertension at that time. Last year, 2 years back, 2015, we witnessed the publication of SPRINT trial, which changed our approach in the management of hypertension, whether the goal would also come down, taking into consideration the SPRINT trial reports. The SPRINT trial reports actually changed the idea of many of the guideline developers, including the ACC-AHA people. And in fact, they had analyzed all the data, including randomized control trials with a strong type of evidence, with a meta-analysis which included multiple studies they had taken into consideration, and they had come out with the recommendation that we need to bring down the systolic blood pressure to less than 130. Now, if you just implement this in the United States itself, it is going to jump by about 14%. The prevalence what was actually about 32% when the levels were more than 140. And now if you are bringing it down to the levels of 130, additional burden even in the United States by about 14% increase. What is this SPRINT trial? Many of you in this audience would have come to know by this time. The question that was raised by the SPRINT trial developers was that bring down the systolic blood pressure less than 120 and compare it with the people who are bringing down less than 140. If that is compared, probably we'll get some ideas about how to probably manage the risk. If surprisingly, people who had gone into this sort of intensive control of blood pressure, bringing down the systolic blood pressure less than 120, has shown beneficial effects in the primary outcome involving MI, ACS, stroke, heart failure, death from cardiovascular disease to the extent of 25%. It is not only that, the all-cause mortality, the cumulative hazard, included everything, and that has come to the level nearly about 27% risk reduction in those people who had an intensive control of blood pressure less than 120 systolic when compared to people less than 140 millimeters of mercury. However, these investigators of SPRINT trial had used more than 3 drugs to bring down the blood pressure in this group of people to achieve less than 120 millimeters of mercury. But it also resulted in acute kidney injury in some patients, hypotension in some patients, electrolyte disturbances also. But however, mortality did not occur. What is important here is to appreciate the way in which the blood pressure was measured in SPRINT trial. It is not the usual blood pressure what you measure and what I measure in our clinics and in the general hospitals. It is not possible to implement the things what had been advocated by the SPRINT trial group of people. The people actually were entering into the room where the air conditioned, they were all given newspaper, they were asked to take rest for about 5 minutes, they were comfortable in the room. Unsupervised estimation of the blood pressure by the semi-automated oscillometric methods of measurement of blood pressure. 3 readings were taken. The average of the reading of the blood pressure of that particular individual he was recruited for the study. For each and every visit when the person was coming back to the investigator, again the same method of estimation of blood pressure was conducted, and that was the result which was continuously taken into consideration for the measurement of blood pressure. That is something unusual which was not practiced in the past. That's one thing which attracts our attention. Does it mean that we should always adhere to this part of examination of the blood pressure for every patient? That is not possible in a huge practice or in a big hospital. So the investigators have come to a reasonable conclusion that what was depicted as 120 millimeters of systolic blood pressure in SPRINT trial is almost equal to 136 to 140 of systolic blood pressure in the office. The diastolic pressure of 76, which was estimated there, is equal to about 82 or 84 diastolic blood pressure. Apart from the SPIN trial, the ACC-AHA guideline developers had taken into consideration one important meta-analysis, which included nearly about 123 studies involving 613,000 patients, and every 10 millimeters mercury of systolic blood pressure reduction resulted in about 20% reduction in CVD, 17% reduction in CAD, 27% reduction in stroke, heart failure reduced by about 28%. What is important in this meta-analysis, the all-cause mortality came down by 13% with a good control of blood pressure by reducing only systolic blood pressure to the level of only 10 millimeter. They also had come out with an information about the drugs usage. For example, the beta blockers were found to be inferior in many studies. The CCBs were found to be superior for stroke prevention. However, it was inferior for heart failure. Diuretics were superior for heart failure. The overall information, what we get out of this meta-analysis is that it strongly supported for lowering the systolic blood pressure to less than 130 over 80 millimeters of mercury. The benefits that were seen in those people who had a history of cardiovascular disease, coronary artery disease, stroke, diabetes, heart failure, as well as CKD. There's a valid information what these people had obtained from this meta-analysis. Apart from this, they are also looked into various studies with the help of other organizations, and they were able to come out with this sort of recommendation that you need to bring down the blood pressure to less than 130. So the goal is 130 over 80 is a goal that was supported by the ACC-AHA. The classification is also simple classification, which you can understand, I can understand. Even in the middle of the night, if you ask me, probably I'll be able to tell you the recommendation given by ACC-AHA. Normal, 120/80. Elevated, 120 to 129 systolic, and the diastolic is still around 80. Hypertension stage 1, 130 to 139, and 80 to 89 diastolic is considered as stage 1. Stage 2, anything that is above 140 and 90, which we were all considering as normal in the past, it is stage 2 hypertension by the designation that has been given by ACC-AHA. Very simple classification which everybody can remember. What is important here, the normal and the elevated combined, you get it as a pre-hypertension by JNC7. JNC7, which had introduced this terminology of pre-hypertension, covered not only the elevated blood pressure of the ACC recommendation today, but also the stage 1 hypertension. That is most important. The pre-hypertension terminology is now removed, and now they call it as one is elevated, the other one is a stage 1 hypertension. Now, the recent publication of 2018, the recommendations, the classifications as far as the threshold for identifying people with hypertension has not been changed since 2013. 2013, what was designated, what was given, the same thing is now being depicted as an information from the ESC as well as ESH guidelines. What is important here, again, to tell you that the normal and the high normal blood pressure, what is now coming out from the ESC ESH guidelines is nothing but the pre-hypertension by the JNC7, which is now called as elevated and stage 1 hypertension of ACC-AHA. So, ladies and gentlemen, this is an excellent information what I thought I should share with you. People who were having normal blood pressure, in the course of next 4 years, most of them develop pre-hypertension. That's the study of Birmingham data, which we are able to get it from the follow-up. The study also had included about people who are above the age of 80 years. Above the age of 80 years, many people had developed pre-hypertension, and the risk of developing a cardiovascular events is almost double. Normal people 9.5%, whereas people who develop pre-hypertension above the age of 80 years, they actually had to face nearly double the risk of developing a cardiovascular event. Now let us look at the pre-hypertension as well as the problem of associated conditions like diabetes. This is a strong heart study which had started emphasizing the role of pre-hypertension in increasing the cardiovascular events. Compared to the normal, very high. Compared to the people who had pre-hypertension, the diabetic people are at a higher risk of developing a cardiovascular disease. But when you have pre-hypertension with diabetes, the risk of developing a cardiovascular event is much more, thereby emphasizing the impact of pre-hypertension in people with the diabetes, how careful you should be in treating people with diabetes and identifying those at a high risk of developing a cardiovascular disease because of pre-hypertension. Now, this analysis had clearly shown in a 7.7-year follow-up of more than 2,500 people, those people who were maintaining the levels less than 140/90, the events actually were more when compared to people above 140/90. Now, look at the evidence as far as the meta-analysis is concerned, which had involved nearly about 90 studies, with the reduction of only 8.2 millimeters of systolic and 3 millimeters down of diastolic blood pressure in all these studies. People were able to identify that there is a good benefit in stroke events, the coronary artery disease events, all-cause mortality, all-cause death. Everything has come down with the administration of the drugs in the intensive group and compared to the control group. Very important information that we are obtaining from this meta-analysis, which had given us information that we need to use drugs and should approach intensively in controlling the blood pressure to get the maximum benefit. Look at this data. Above the age of 70 years, older people, are they going to get benefit? Yes, you should not hesitate to treat these patients because there is enough of evidence. Primary outcome actually has come down nearly about 36% compared to the conventional treatment group. The same way, all-cause mortality in people above the age of 75 years are also shown nearly about 33% reduction in all-cause mortality if you are able to treat people above the age of 75 years. Again, stressing the importance of treating elderly people also. Based on all this information, the recommendation by the ACCHA, use diuretics, yes, ACI, ARBs and CCBs. There is no mention about beta blocker as a primary drug. Beta blockers had been pushed as a secondary drug. And the primary drug among the diuretics, chlorthalidone is preferred on the basis of prolonged half-life and proven trial reduction in cardiovascular disease. This is a simple recommendation given by ACCHA. Look at it. The goal should be 130/80. Whether the fellow comes under the general category or comes with a comorbid condition, whatever is the problem, you should keep the levels of blood pressure less than 130/80. That's all. As far as the threshold is concerned, only in two areas it gets varied. If you are getting a low risk people, probably 140/90 should be the threshold. If you have problems of secondary stroke prevention, probably the threshold should be 140/90. The rest of the people in the general category as well as in the comorbid condition category should have a threshold of 130/80. So simply remember this number 130/80 should be the goal. Now let us see. This year we got the publication of 2018 guidelines that shows the difference. Here is 140/90, it is 130/80. And the BP targets again 140/90, 130/80. And less than 65 years you can bring down to less than 130. Above 65, less than 130, and above less than 140. Like that. The scoring system was used by the ESH people, whereas ACCHA cohort was used. So ladies and gentlemen, the definition of hypertension, the European guidelines has not changed the definition, the classification of hypertension of 140/90. But this is in sharp contrast to the American definition of hypertension of 130/80. The definition has baffled many of us, has led to significant confusion. What is the truth? American guidelines relate heavily on the clinical studies showing the incremental benefits of CV protection with the decreasing BP levels, whereas the European guidelines relate mainly on the population attributable risk from the epidemiological observation. Are we getting any clarity? In essence, it is a divergence between these two transatlantic guidelines. Very important to note that both guidelines converge on a common BP treatment of target of 130/80. This is depicted here. See, there's a divergence. As far as the definition is concerned, one is saying 140/90, one is saying 130/80. But the goal, it is 130/80. So we have the problem of divergent effect as well as the convergence in the form of guidelines. Both the guidelines agree to one important point. Aggressive control of blood pressure is important, but never keep it around 140/90. This is not acceptable in most of the patients. The clarity, ASH guidelines started talking about the South Asian population. They are at a very high risk from hypertension-related disease burden. So can you implement all these guidelines in our country? Jaipur Heart Watch study started talking about the stage 1 hypertension, which has been actually published by Dr. Rajiv Gupta, which has said about this problem. Can I take 1 minute? Is it okay? That's right. So the stage 1 hypertension has got, there is enough evidence even in our country. I think people have not gone through that. Nearly about 148,000 patients in Mumbai cohort study had indicated that many people were seen with 120/139 and 130/139. There's a stage 1 hypertension has more events and more cardiovascular deaths, particularly high HD deaths. The more events were occurring when this pre-hypertension stage is reached in this study. Venkat S. Ram has actually published this particular study, which was conducted in a semi-rural area, Aragonda of Chittoor district of Andhra Pradesh. Has revealed many people, 39% of them are pre-hypertensive. They are likely to jump into hypertension group. So whatever is the definition of hypertension, the percentage of population with unabated hypertension is too large, leading to inevitable health consequences to our country. It is wise for India to adopt the best features of both guidelines. So BP levels of more than 130 over 80 is the warning signal of impending disaster if the BP trends are not reversed. To protect our huge population from excessive morbidity and mortality, we need to aim for a goal of 130 over 80 in our patients' hypertension diagnosed by whatever is the definition. Ladies and gentlemen, we need to be committed. We need to be aggressive, not to control just hypertension, but to concentrate on every possible risk factor in people with hypertension right from the time of diagnosis. This is self-explanatory. The person keeps only his hand. The doctor is in a hurry to punish him with some pills, but doesn't bother about his examination. He's an obese fellow, he's an alcoholic fellow, he's a smoker, has got features of metabolic syndrome, maybe with diabetes or not. You need to go through the entire problems of the individual who seeks advice for blood pressure reading. Very important. Guidelines that are not followed are of no value. Thank you very much, ladies and gentlemen, for patient listening.
Keep a session for question and answer. Short. Call all other speakers to come on dance, please. Please, sir. Sir, please. So, okay, I'll ask Dr. Kubawat to felicitate the speaker. So I have first question for infectious disease part. So what is the commonest infection we see as a diabetic patient, and what extra care you always ask to your patient?
First of all, I think whenever we manage a diabetic patient, we must aim at a euglycemia. And especially we need to be careful about, all you know, that SGLT2 inhibitors, which are glycosuric drugs, may predispose to urinary tract or the genital infection. So you need to give out precautionary advices to the patient. Out of so many issues, the giving an outline of various peculiar infection in diabetes was to keep in mind that this can happen to the patient. Eye sees what mind knows. We need to be very careful that it could be a rarer kind of infection like mucormycosis, or it could be emphysematous cholecystitis or pyelitis, or it could be a fungal infection in the lungs, etc. So you need to be very careful if the patient has any infective pathology in a diabetic patient. You are asking about the common infection which in a diabetic patient, the common infections are asymptomatic bacteriuria is one of the very common thing. Then pulmonary infections, recurrent, are very common to happen in diabetic patient. We are very prone to have viral pneumonias these days. We have in a winter season coming the H1N1 swine flu. So all immunocompromised people, the pulmonary infection and viral pneumonias are very common, asymptomatic bacteriuria. And above all, we need to be very careful about diabetic foot disease and superadded infection, because as the duration of diabetes goes on, the vascular as well as neuropathic component goes up. The neuropathy causes the atrophy of the small muscle, shifting of the pressure points, trophic ulcers, getting secondarily infected. So these are the common infections. We need to be careful about it. But euglycemia stays, and above all, even if the patient is undercorrected, the vaccination has a definite role to build up the immunity. which is very important.
Even for the audience, please. Yeah, please.
Sir, this is question to Dr. Sambit Das. What's your take-home message from these new classification? First, are you going to adopt these into your clinical practice, or you wish that RSSDI should make a consensus, some consensus as to whether to follow or reject, or maybe perhaps a great solution could be to a small set of patients, as Dr. Bansi said, that you should reject majority of patients for this investigation, but when you feel clinically that this patient is likely to be investigated because it's a doubtful case, maybe a Modi or a LADA, then you should go for this panel.
Yeah, I think that's very pertinent, and at this juncture, I think just adapting that cluster classification to the Indian setup would be too premature actually. And what Dr. Bansi has actually told, it's very practical. We need to first see the patient clinically. We can grossly classify the patient. Whenever we have a doubt, like the patient is lean, GAD antibody negative, we have some doubt about whether it's type 1, type 2, LADA or MODI, then only we can go for the battery of tests like C-peptide and the GAD antibody, and then we can find out what the cause is.
Can I have next questions for this speaker? This question is to Dr. Raman Puri, sir. Sir, any brief idea of clinical use of saroglitazar, if you at all you are using in practice, and what patients, how, when, and do you stop statin or you continue with that?
See, I told you that we do not have any cardiovascular outcome data so far of any of saroglitazar at all. So we do not recommend saroglitazar because there is no cardiovascular outcome data. So we will not recommend. This is our recommendation, but of course it's a personal whether a physician wants to use it or not, because it does reduces triglycerides significantly. There are only one trial which have shown a positive result, is a Zealous trial, and which have shown that there is a significant reduction in event when omega fatty acid is added, EPA is added on over and above statin. We are expecting results of reduced trial, which is expected end of this year, and the strength trial, which is expected in 2019. So if these two outcome trials are positive trial, then at least omega fatty acid, either as an ecospent ethyl or carboxylic fatty acid, omega fatty acid, can be used as an adjunct therapy to reduce triglycerides over and above statin if triglyceride levels are high. But at present, since there is no outcome data for saroglitazar, we do not recommend that.
Thank you, sir. The last question to Dr.
Sir, can we please restrict, because there are people wanting to ask. Sorry.
Yeah, my question is to Dr. Singan. Now, at the time of detection of diabetes, if the patient has the blood pressure of 120 and 80, now if we drop to 110 and 70, and if the patient is comfortable with 110 and 70, then does it drop give benefit to prevent the CV risk factor, CV risk?
Lot of noise.
With or without medication, whatever.
At the time of diagnosis, the blood pressure is 130 over 80.
120, 80.
120, 80.
Yes.
Subsequently, it has touched 110 over 70.
110 and 70. So does this drop of 10 millimeter of mercury give any benefit to the patient for the prevention of CV risk?
Now, 130 over 80, if the person is seeking advice for the first time to get a label as diabetes, you don't push him to the label as hypertensive. You wait for some time and then try to analyze the data and then look at the pressure again and again. Probably home blood pressure monitoring or ambulatory blood pressure monitoring will tell you whether he is really suffering from hypertension. Only then you are expected to put him on either lifestyle management or pharmacological therapy.
Okay, thank you.
Sir, one question to Dr. Puri, sir. In reference to lipids, we always talk about the fat intake. A lot of importance nowadays has been given to fructose as one of the main culprit for de novo lipogenesis in the body. So your comments on fructose?
Frankly speaking, I have no idea about it, And only think if glucose increases triglyceride more or fructose increases triglyceride more, if any one of two increases, that should not be used. But what I discussed with Dr. Narsingan is that fructose is better than
it is worse than.
Worse than glucose. But I have no idea myself.
Fructose is directly counted to triglycerides and fats by the liver as compared to glucose.
I don't know because it has not been.
as we are running slightly delayed and schedule, we are closing this session over here. I thank all the speakers for their nice introduction, and I ask Dr. Deepak to felicitate our chairpersons, Dr. Vidyut, Dr. Kirit Kubat, so Dr. Vidyut sir. Dr. Ranjan,
I would like to request Dr. Kate Kubavat to felicitate Dr. Gaurav Chaya sir. Thank you all. Thank you so much. There is a small announcement is there. There is a feedback form in your registration kit, that bag. Please fill it and give it to, submit it to the registration desk. Second one, we are going to play a small video. For the last session of our DiaCon, I would like to invite Dr. Krunal to moderate the session. Please, sir.
Good afternoon, friends. First of all, thank you, Dr. Bansi sir, for a wonderful event. I think we must have a huge clap for him. This wonderful event which he has done, and I can see the immense hard work which these people have done. So thank you so much for that. Now, just a little announcement that out of 3 topics of quick bites, because of time constraint, we are going to have 2 topics. So first and second topics we'll be going for. And before I start with the topic, I would like to invite first of all the chairperson, Dr. Mukul Oza sir. Very. Oh, fine. So that's good that we are going to have 3 desserts today. Somebody who has taken the lunch. Oh, fine, fine. That's the information given, but that's fine. It's good to have more 3 quick bites. So please, Dr. Mukul Oza sir, please sit with us for the chairing the session. And I would also like to invite Dr. Birju Mori from Rajkot to chair the session. And I'm asking Dr. Mukul Oza sir to invite the first lecture of today's talk.
Wasting time, again I would like to acknowledge Dr. Bansi, academic icon. Yeah, we'll do fast. So straight away going to the first very revolutionary topic, role of gut microbacteria in the pathogenesis of type 2 diabetes. Really revolutionary lecture, sir. Sir, over to you, sir, straight away. Time constraint.
Can I have the first slide, please? Yeah, thank you. Very good afternoon to all of you. I know we are running short of time, but again, thanks to Dr. Banshi and Hardik and all my friends in Ahmedabad for having me here. I've been asked to talk about this very interesting topic as to what's the role of gut microbiota in type 2 diabetes and how we can modulate it to favorably alter the glycemic outcomes. So what do we mean by the gut microbiota? The gut microbiota are actually the microorganisms with which we share our body. There are around 100 trillion of them belonging to several species. They weigh around 1.5 kilograms. And the microbiota do not remain constant from infancy to adulthood. And even within adulthood, during various stages of health and disease, they do keep changing. But bacteria from three major groups represent more than 95% of the total microbiota. And these groups are the Firmicutes, the Bacteroidetes, and the Actinobacteria. So what do we know about the role of the gut microbiota in diabetes? In type 1 diabetes, it has been shown by several studies that there are significant differences in the composition of the gut microbiome in children with type 1 diabetes compared to those without. Similarly, in type 2 diabetes, there have been again hundreds of studies, and in a nutshell, the studies show that patients with type 2 diabetes are characterized by moderate degrees of gut microbial dysbiosis, a decrease in the abundance of some universal butyrate-producing bacteria. We'll talk about butyrate slightly later on in the talk. And as is to be expected, an increase in the various opportunistic pathogens. So this is a nice diagram which I think one of our previous speakers showed us during the talk on fats and oils. And this just tells you in a nutshell what the alterations of the gut microbiota do to the integrity of your intestine and how these alterations can actually lead to the different forms of diabetes. And what they say is that alterations of the microbiota, either due to some genetic influences or due to some environmental influences, lead to gut microbial dysbiosis. And it can lead to diabetes in one of two ways. It can alter the permeability of the epithelium, it can alter the integrity of the epithelium and cause various microbial toxins such as lipopolysaccharides to be absorbed into the circulation, where they can exert their actions on various tissues, either directly or through recruitment of the inflammatory cells, leading to inflammation, metabolic syndrome, and diabetes. More pertinent to type 1 diabetes, some of these microbial antigens can get absorbed into the circulation when there is a defect in the integrity of the gut epithelium, and these can somehow stimulate the immune system and lead to various autoimmune processes, including type 1 diabetes. And when you consume a diet which is rich in fiber, the fiber is metabolized by the gut microbiota into various products, including the short-chain fatty acids. And these short-chain fatty acids are important, number one, in increasing the production of various peptides such as peptide YY and GLP-1, which induce satiety and prevent the development of obesity. And number two, in maintaining the integrity of the gut epithelium through production of GLP-2. When you eat a diet that is rich in refined carbohydrates, rich in fat, there is dysbiosis, increase in the gram-negative organisms in the intestine, leading to production of lipopolysaccharides, which can lead to inflammation, metabolic syndrome, and diabetes, as we have mentioned earlier. So how do you modify the gut microbiome? Are there any ways of changing the gut microbiome in a favorable manner? And there are two ways by which we can think of changing this, and one is by the use of probiotics. Probiotics are live microorganisms which, when administered in adequate amounts through the proper route, confer a health benefit on the host. And these are found in foods such as yogurt, some of the other dairy products such as dahi or curd, and are also now commercially available as dietary supplements. Now what are prebiotics? Prebiotics, to put it simply, are just food for the probiotics. Probiotics are the good guys and the prebiotics are the food for the good boys. These are non-digestible substances and they provide a beneficial environment or a beneficial physiological effect for the host by selectively stimulating favorable growth of these microorganisms, which are good for you. And these are found in whole grains, bananas, onions, garlic, honey, and these are also now being marketed as dietary supplements. So this is what probiotics do. They actually reduce the gut permeability, reduce the production of the lipopolysaccharides, reduce the absorption of the various antigenic molecules into the circulation, and thereby bring down inflammation as well as autoimmune stimulation. So there have been a lot of studies on the modulation of gut microbiota in diabetes, most of which have been done in animals. For want of time, I am not going to go into all of those. But I will just take you through one of the studies which we did at the Madras Diabetes Research Foundation in mice. And what we did was, we had two groups of mice. In one group was fed the normal pellet diet. The other group was fed a high-fat diet with an aim of inducing diabetes in these rats. And the rats which were given high-fat diet were further divided into another 6 arms. The first arm was high-fat diet alone. The second arm was the high-fat diet along with the LGG, that is the commercially available Lactobacillus rhamnosus. And we had two probiotic cultures which were provided to us by the National Dairy Institute at Karnal in Haryana. These were actually the lactobacilli of Indian gut origin. And we also had two positive control groups which were given in addition to the the high-fat diet. They were given metformin and vildagliptin. And as was to be expected, the mice fed to the high-fat diet showed an abnormal oral glucose tolerance, meaning that they developed impaired glucose tolerance. But when they were co-administered the probiotic culture, there was a significant improvement in the glucose tolerance, which was comparable not only with the available lactobacillus, but also with the anti-diabetic drugs metformin and vildagliptin. That is the sort of magnitude of improvement in insulin in the diabetes status which you get. Similarly, if you look at the insulin sensitivity, you feed somebody a high-fat diet, the insulin sensitivity comes down. But when this rat is also fed the probiotic culture, and in this case both the probiotic cultures were shown to improve the insulin sensitivity to a similar extent as the positive control, that is the lactobacillus, and the anti-diabetic drugs metformin and vildagliptin. And this was published in the European Journal of Nutrition just last year. But before we stop all vildagliptin and metformin in our patients and start them on lactobacillus, let's see what the evidence is in human beings. There have been a few trials, not more than 15 or 20, and there have been a couple of meta-analyses also published on the role and effect of modulating the gut microbiome in type 2 diabetes. For some strange reason, many of these trials have been from Iran. I don't know why Iranians are so fond of gut microbiome. Anyone come from Iran, probably they can tell us. But you can see most of the studies are from Iran. They are all of short duration, small number of patients, 50, 60, and these are all the parameters which they have looked at. They have looked at HbA1c, anti-inflammatory markers, fasting plasma glucose, and some of them have also looked at the anthropometry. So we can see from this meta-analysis that it does seem to have a favorable effect on the fasting plasma glucose. The odds ratios favor the probiotic use. Not that much of an effect on the HbA1c. Probably the duration is not long enough. Some effect on the insulin fasting, insulin concentrations. Again, not that much of effect on the insulin sensitivity. So the effects, if any, can be expected to be mild. Now, more recently, while I was preparing for this talk, I came across this particular systematic review which assessed the same thing they looked at, but probably with a couple of more studies because it's a couple of years down the line. I was surprised to know that they still had only 8 studies because the rest of them did not meet the selection criteria. And what they have done is they looked at whether dietary interventions, number one, can they modify the gut microbiota? And number two, do these modifications actually translate to improvement of glycemic outcomes? And here we find that the authors of this meta-analysis have come to slightly different conclusions than the previous meta-analysis that I mentioned. Here the HbA1c is improved but not the fasting plasma glucose. And there was not much of benefit as with respect to the fasting insulin or the HOMA-IR. And there was minimal or no effect on inflammation, the levels of short-chain fatty acids, which I already talked about, and the anthropometrics. So just changing the gut microbiota to lose weight may not be a very good idea. And they conclude that while there was some evidence to show with the available data that modulating the gut microbiota can improve glycemic control, still the evidence is far from being accepted as standard of care. Still we need many larger studies in various ethnic groups because ethnicity also plays a big role in this. Another important question which we need to get answered is the safety of probiotics. Because remember, these are live microorganisms. We do not want a situation akin to the the vaccine poliovirus becoming wild and causing vaccine-induced polio. And this is all the more important because these people are immunocompromised just by virtue of having diabetes. Now we have 622 trials, and these are trials not just for diabetes but for various disease conditions in which probiotics have been given. And this particular meta-analysis showed no difference in relative risk of any adverse event between the intervention group and control groups. They're as good as or as bad as placebo as far as adverse events are concerned. If any, the adverse events were mild and they were referable to the gastrointestinal system, naturally, because that's the route of administration, and they were relatively short-lived. But if you tease out the studies in which these agents have been given to really immunocompromised individuals, say for example those who have neutropenia or those who are on chemotherapy, I don't know why anyone should give a probiotic to any of those patients, but people have probably tried those. And in those situations, which probably we will not be coming across too much in our practice, there have been case reports of fungemia, bacteremia, and sepsis. So probably you should avoid it in people who are really immunocompromised. So I'd like to conclude by saying that there is now substantial evidence for a link between gut microbial dysbiosis and obesity, insulin resistance, and type 2 diabetes. Various mechanisms have been postulated. Animal studies have been more or less positive. They do show a beneficial effect of probiotics in prevention and control of type 2 diabetes. Human studies have been inconclusive, but there is a signal that they may be useful. But what's the dose, what is the route of administration, what is the duration of administration remains to be elucidated. Therefore, we need larger and longer term randomized controlled trials which are adjusted for confounders such as diet profile, drug use, BMI, ethnicity, and so on and so forth, before we can conclude that this has become a standard of care in treatment of type 2 diabetes. Thank you for your attention.
Thank you so much, sir. And thank you so much for saving the time for the speakers also. I would like to facilitate, sir, Dr. Mukul Oza, sir, would facilitate you.
Now I would like to request Dr. Supratik Bhattacharya from Kolkata. I'll just cut short the introduction for the sake of time constraints. Thank you.
Can I have the first slide, please? Good afternoon, everyone. Thank you, Dr. Sabu and the entire team DiaCon for their kind invitation. And it's a wonderful city, Ahmedabad. And when I was given this topic, I was pleasantly surprised because unlike the topics usually what we talk about being an endocrinologist regarding diabetes, this was something entirely different. So we are talking about, does evidence translate into clinical practice? And by that we mean we have a lot of researches that go in before it is actually incorporated into our clinical practice. So what are the various steps that take place and whether we actually implement exactly the same things what we conclude from clinical researches, or are there any variations while we do that? So how does it all start? So we start with the basic research that goes on to the human research, the clinical research. Finally, a group of people sit together forming guidelines, and that guideline is taken into the clinical practice. So it's something like this, you know, if the clinical researches are like the F1 racing circuit, your clinical practice is something like the metro, driving in a metro city at the peak of the traffic. So there is a lot of difference. So in the first situation, everything is perfect, whereas in your practice, every single case is individualized. So one rule doesn't apply to all, neither there are very stringent rules or regulations, and you have to apply your clinical knowledge based on the guidelines and then decide what is best for your patient. So why do we need this evidence-based medicines? So this is the definition of evidence-based practices: systematically developed statement to assist a practitioner about the decisions and appropriate health care for specific clinical circumstances. What are guidelines? They are there to reduce the inappropriate variations in clinical practice. So you can see one guy standing there in the red suit while everybody else is falling in line. So in order to reduce that kind of inappropriate individual variations, we require guidelines. So what are the components of evidence-based practice? So you have the patient factor. So whenever the patient comes to you, you ask the patient, what is your expectation from this particular consult? And you'd be surprised to know that many of your patients has done a lot of background research before they come to you. So now you have to match that expectation with the clinical data or knowledge that you have in hand. And finally, what is the kind of research evidence to back that understanding, leading on to an optimal clinical decision. So this is not uncommon in your clinical practice, what we call a Google doctor. So everybody sits in front of your internet, they search their symptoms, they find out their diagnosis, they come up with the best possible treatment for them, they look at every single small letters, side effects, and they will come and question you about that. So many a time, it's a face-off or a showdown between the doctors and the Google doctors. So the practice of evidence-based medicine had started many years before. So as you can see in here, it started in 900 AD when Al-Razi had put one group as the control group and the other group which he treated just to find out if there had been any difference between the two groups. That was the start of evidence-based medicine, and then we progressed all the way. So the integration of individual clinical expertise along with the best available clinical evidence from the systemic research leads on to a better healthcare. So what are the components of the individual clinical practice? The skills of the doctor, the judgment that you acquire over the years that you have practiced, and the experience of the patients. So where does this evidence come from? From basic medical sciences, patient-centered studies into the safety aspects, but the best evidence comes from the systematic reviews. So if you see the level of evidence, on the top are the systematic reviews and meta-analysis of the prospective double-blinded randomized controlled trials, followed by all other things. So textbooks are probably much lower down. So expert opinions, textbooks are not going to save you if you get litigated in court. So you have to have a much higher level of evidence to support you. So, of course, higher the level of evidence, less is the chance of any kind of bias, and more plausible and precise will be your deduction. So why this sudden interest in the evidence-based practice? Because it had been found out that if a clinician has been practicing for many number of years without any accompanying updating of knowledge, it leads on to a decline in the clinical performance. And that's why you have so many CMEs and scientific programs to aid you to update your knowledge. Then there is a need for valid information regarding the diagnosis, therapy, prognosis, etc. And then, most importantly, if you remember, the common man now, because of the internet, has access to various medical journals, medical informations that are available freely on site. And limited time that is available to the clinicians to actually read up on the journals. So realistically, if you have to be on the top of the game, you have to read around 19 articles per day, 365 days per year to be on the top of your game. Whereas, realistically, a busy clinician would be ending up reading less than 1 hour per week. So, research evidences does not always translate into practice for the obvious reasons. So it's something like this. It starts off looking like this, and by the time it comes to your clinical practice, she has become a pretty young woman. Okay? She was pretty earlier as well, as an elderly, but she has become prettier as a younger woman. Okay? So the EBM challenges, of course, stays about the awareness about the guidelines that are available, whether it's applicable to the other kinds of subsets of people, familiarity of the clinician to the various guidelines, agreement about the different guidelines, and the success and expectations, and finally, motivation of the clinician to actually implement these guidelines into their practice. So what are the strategies to move from evidence to action? So you have different options in front of you. Now, what really matters at the end of the day is what gets you success. That's all. You might have an armamentarium of treatment given to you on the platter, but at the end of the day, what matters really is what brings you success. So the steps to ensure evidence-based medicine are clinical predictions, knowledge transfer, grade recommendations, asking clinical questions, and finally a 5-step approach. So what are CRPs? These are mathematical tools that quantify the contributions of various aspects like the history taking, clinical examination and diagnostic tests that stratify a patient in terms of probability of having the target disorder, which is known as a diagnostic CPR, or the future health outcome, which is known as a prognostic CPR. So this is one of the validated tests for implementing evidence-based medicine. What is the advantage? It can accommodate many factors which are beyond human brain. The data consistency will be maintained and more accurate, but it may not be user-friendly or easy to adapt. So the clinical questions that we put into context can be put as a PICO model. By that, this is the example. So you ask in a patient, in the population, in a patient with myocardial infarction, does treatment with statin at an early stage compared to the placebo really has any effect on the final outcome or not? So this is a clinical question that you put out, and then you try to find the answer to that by looking up various literature. So framing an answerable question is the first step. Then you search the literature, various journals, you do an internet search to look for the evidence that you have to back up this. Then you have to have a critical appraisal about the literature. And finally, you integrate all the evidence that you have in hand with the clinical expertise, taking into account the welfare of the patient and the best interest of the patient. And finally, once you've implemented that, you have to evaluate the success in doing so. So the advantages of evidence-based medicine is the potential to improve the quality of patient care. It promotes the practices that are proven scientifically. It identifies the ineffective and harmful practices. It promotes critical thinking, which is a high level of cognition coming into play. It requires clinicians to be open-minded and encourages researchers to focus on evidence and outcomes that are important to the clinicians. So let's unite to act on behalf of our patients and provide solutions to their unsolved clinical needs. So what is the main difference between a person who practices evidence-based medicine? He is happy because he has done his part. He's happy because he's not going to get litigated in court. Okay? Whereas in comparison to another person who is only treating patients based on his previous clinical experience, he's always thinking, will the patient recover or not? Will they sue me in court? Will there be a bad reputation attached to my name? With that, I just put up, this is the person who was associated with all the UKPDs, Dr. Rudy Holman. And thank you so much for your kind listening. And it has been an absolute pleasure to be here in Ahmedabad. Thank you so much.
Thank you so much, sir, for a wonderful talk. I would like to, sir, please be on the dais. I would like to ask Dr. Bijju Mori to felicitate our speaker.
So straight away we are going to the third lecture. Dr. Pramod Gandhi from Nagpur, sir. He'll be giving talk on controversies in diabetes in primary care. Over to you, sir.
Yeah. A very good afternoon to you all. As a last man, I would like to discuss one very important thing which we have learned since last 2 days. In spite of listening so many good talks, we still have controversies in diabetes. There are many clinical controversies, many non-scientific controversies we know. The non-scientific controversies, like there are people who claim that we can cure diabetes, there are people who claim that you don't need to control blood sugars well. I am not going to discuss all those things. What I am going to discuss for all our primary care physicians is the important controversies which we have faced in 2018. The one of them is what should be the target HbA1c in patients with type 2 diabetes mellitus? What are the different types of diets which you have been listening since morning? And should we use statins
in all our patients with type 2 diabetes mellitus or not. Now, let's see. In March 2018, I remember one of my friend, he suddenly called up in the morning and he said, see, my HbA1c is 7.8 and I am happy. I said, why? He said, recently there has been American College of Physicians has published certain guidelines and which says that your HbA1c of 7 to 8, you are happy. Now the whole controversy was generated on 6th of March 2018 when ACP or American Association of Family Physicians has also published that these are the guidelines which were published in Annals of Internal Medicine in April 2018, which says that the target HbA1c should be between 7 to 8%. Now, let's understand what does it mean? Why there is a controversy? All other guidelines like AAC, ADA, ICSI, NICE, SIGN, RSSDI guidelines, all these guidelines suggest that your target HbA1c should be less than 6.5 to 7. Now, what are these statements which were made by the guidance statement which were made by the ACP? Let's learn those statements and read those statements carefully and understand the meaning of these statements. The guidance statement one which says that clinicians should personalize the goals for glycemic control, which otherwise also all other guidelines also says that you should individualize the goals for glycemic control in every patient with type 2 diabetes mellitus. The AAFP also says that your target HbA1c should be based on general health of the patient, life expectancy, treatment burden, and cost of the care. I feel even AAC or ADA, ESD also says the same thing, that your target HbA1c should be based on risk of the hypoglycemic drug, risk of hypoglycemia, adverse drug reactions, disease duration, life expectancy, relevant comorbidities, established vascular complications, patient's attitude towards the treatment, and the resource or cost which is expected to the patient. So all these things has to be taken into consideration, with more stringent goals should be applied to the patient who has at minimal risk and who can afford, whereas a patient who has high risk with limited support system should have a higher HbA1c which should be acceptable. The guidance statement 2 says that clinicians should aim to achieve HbA1c level of between 7 to 8%, which has generated a real controversy in most patients with type 2 diabetes mellitus. Whereas all other guidelines says that a reasonable goal of HbA1c should be less than 7%, which is said by ADA, whereas AAC says that it should be less than 6.5. The guidance statement 3 says that clinicians should consider de-intensifying the pharmacological therapy in patients with type 2 diabetes mellitus who achieve HbA1c of less than 6.5. Whereas the ADA says that consider more stringent goals of maybe less than 6.5% for a selected group of patients where it is achievable without any significant risk of hypoglycemia. That's very important statement. If you are not able to achieve this HbA1c without increasing the risk of hypoglycemia, your HbA1c of little higher side is higher HbA1c is also acceptable, where they say that consider less stringent goals, maybe up to 8% for patients with history of severe hypoglycemia, limited life expectancy or other comorbid conditions that makes HbA1c less than 7 or less than 6.5 difficult to achieve in these group of patients. So same thing which AFP is saying. The guidance statement 4 says that clinicians should treat patients with type 2 diabetes, type 2 DM, to minimize symptoms related to hypoglycemia, hyperglycemia, and avoid targeting HbA1c levels in patients with life expectancy of less than 10 years due to advanced age, or those patients who are residing in nursing home or with chronic comorbid conditions, in these patients, HbA1c of 8 is acceptable. The same thing has been said by ADA or AAC as well. Now, why ACP or AAFP has given these guidelines? Possibly, they have looked at this data, which we have all seen, all of us have seen since last 2 days, that UKPDS, DCCT, EDIC, even the recent 3 studies, Advanced Accord and VADT, all these studies have shown there is no significant benefit in terms of cardiovascular risk. However, UKPDS extension had shown, or UKPDS follow-up study had shown, that there is reduction in the cardiovascular mortality in this group of patients. Whereas Accord had shown slight increase in mortality in those patients in whom HbA1c was achieved very low or maybe less than 6.5 in the intensive arm. And that might be the reason of the ACP recommendation. However, de-intensifying therapy for patients below 6.5, that is the recommendation which is given by ACP, the finding is not relevant for all patients of type 2 diabetes mellitus, specifically who don't have heart disease or younger patients who do not have any comorbid conditions. What is the evidence? Just now we heard that we should have an evidence for this. We know that the Advanced Accord and VADT trial had not shown any benefit in terms of cardiovascular morbidity, because all these studies had taken patients with long-standing diabetes who has already established coronary artery disease, and that was the probably reason for increased risk. There was no benefit of cardiovascular morbidity, and in Accord study probably there was increased mortality in intensive arm, probably because these patients has already established coronary artery disease. Whereas in UKPDS studies, these were the newly diagnosed patients where the UKPDS follow-up has clearly shown that intensive glycemic control in diabetes mellitus reduces long-term risk of myocardial infarction significantly. There was p-value is significant in terms of long-term risk reduction in microvascular as well as microvascular complication. Also, ACP and AFP has focused only on macrovascular complications, that's coronary artery disease. What about microvascular complications? There is enough evidence to say that intensive glycemic control definitely helps in reducing microvascular complications of diabetes. That is, retinopathy, nephropathy, neuropathy has been reduced significantly, and that's why even AAC 2018 guidelines recommends that we should individualize the goals for glycemic control in every patient. Target HbA1c should be less than 6.5 for those patients without concurrent serious illness, or those patients who are at low risk of hypoglycemia, or HbA1c of more than 6.5 may be acceptable in those patients with concurrent serious illness or comorbid conditions, and those patients who are at risk of hypoglycemia. This issue is discussed here is only because most of the patients are treated by family physicians, and these guidelines might mislead these patients to poor control of our patients. The next controversy, there are different types of diets which you must have heard and seen in day-to-day practice, but then these two different diets which has really created controversy in last few months. One diet says that you should have only 2 meals in a day and your weight will be controlled, your sugars will be controlled. The other diet says that you should eat every 2 to 3 hours and your sugars and weight will be well controlled. But then you have had a full session on diet. What I am going to give you is just broad outline and the recommendations which are given by ADA, which says that we should promote and support healthy eating pattern, emphasizing the various nutrient dense foods. Our target should be to achieve and maintain body weight, to attain individualized glycemic, blood pressure and lipid targets, and by this we should try and delay the long-term complications of diabetes. At the same time, we need to address the individual dietary needs based on patient preferences, health literacy, availability, So these are the practical approaches which we should follow in our while advising nutritional guidelines, and we should individualize the medical nutrition therapy to each and every patient of type 1 or type 2 diabetes mellitus in our day-to-day practice. Although there are several popular weight loss diets are available, the randomized trials had shown that these diets had been shown to reduce modest weight loss, and the weight loss is possible only in those patients who are compliant, who are following these diets regularly. Otherwise, overall, low-calorie, carbohydrate-restricted diets have been shown to be effective in reducing weight, in reducing insulin resistance, serum triglycerides, increased HDL cholesterol, and probably that might help in our type 2 diabetes mellitus patient. So we must individualize the diet. The next controversy is, should we use statins in all our patients with type 2 diabetes mellitus patient? We know that CVD is a leading cause of morbidity and mortality in patients with type 2 diabetes mellitus. It also adds to cost. The common coexisting condition which increases the risk of cardiovascular mortality and morbidity is hypertension and dyslipidemia, which are the clear-cut risk factors for the ASCVD, and diabetes itself confers an independent risk factor. Now there has been enough data to show that this is a meta-analysis of more than 102 clinical trials which has shown to increase the risk of adverse CV events in patients with diabetes. The major contributory factor, these are all the major contributory factor, amongst them this atherogenic dyslipidemia, that is small dense LDL particles are increased triglycerides and low HDL. This is a classical atherogenic dyslipidemia which is seen in patients with diabetic, is a major contributor. We all know that diabetes is CAD equivalent. Dyslipidemia should be evaluated and managed aggressively. For management of dyslipidemia, we should evaluate these patients at diagnosis or at first evaluation and subsequently depending on the patient's requirement. The treatment is, we must focus on therapeutic lifestyle changes. That is the major focus. We should target therapeutic lifestyle changes by following diet, exercise and weight loss, and statins should be given in select group of patients. What are those patients? There is enough evidence by HPS study, CARD study. These are the meta-analysis of various studies which had clearly shown that statins reduces the adverse cardiovascular events in patients with diabetes mellitus significantly, and hence the ADA recommends that all patients of type 2 diabetes mellitus, except patients less than 40 years who do not have any associated risk factor, should be given moderate or high intensity statin therapy. Only a small subgroup of patients of type 2 diabetes mellitus with age less than 40 years and no other risk factors are spared. Otherwise, all these patients should be given statins. This is stated even in 2018 ADA guidelines as well. Statins do have additional benefits, what we call as pleiotropic benefits. These are the high intensity and moderate intensity statin therapy which we have discussed. In short, to conclude my talk, I can say that we must target HbA1c to less than 7% and it should be individualized. Diet also should be individualized. Statin should be given to all patients of type 2 diabetes mellitus more than 40 years of age. And even those patients who are less than 40 years of age with multiple risk factors, we should give statins. Thank you. Thank you for your patient hearing.
Thank you very much, sir. I'm very sure that this topic of yours will go a long way in the history of DiaCon. I think it's a topic of the day 2018 because it was a very fundamental topic for physicians in clinical practice. All the three speakers were absolutely brilliant and fantastic, and I don't think that they have made, they are so clear that there are no scope from questions from the audience.
Thank you.
So I think we conclude the session on a very big good note, and robust round of applause to Dr. Gandhi, sir. I would request Dr. Kunal to facilitate him.
Yeah. I would like to ask a Team DiaCon person to felicitate our chairperson. Dr. Birju Mori has came all across from Rajkot. Dr. Mukul Oza, sir.
I'll request Dr. Mukul sir to, both of you, please both of you, to felicitate Dr. Kunal Javeri. Thank you so much. Thank you so much, all of you.